Good afternoon. I'd like to call our Social Services Subcommittee to order. We have an extraordinarily long docket today with 27 bills, and so we are going to try to move through our docket, and a number of us have bills to present in other committees, so I do anticipate we may have to go at ease this afternoon a couple of times to make sure those bill hearings get heard as well. And I know committee members are also on other committees, so you'll see us come in and out. If you follow our Social Services Subcommittee, you know that I love to give everybody an opportunity who has waited all afternoon to be able to provide their testimony. But because of our extraordinarily long docket, I'm going to ask today that we keep witness testimony to 1 minute per person, and we will set the timer. Please adhere to that timer. I would hate to have to interrupt and call time on you, but that way we are able to give everybody an equal opportunity to testify. All right, and with that, we're going to take attendance. Great, thank you so much. We have a quorum. I just want to say hello to our VCU pharmacy students. I love to see students and young folks come in and be able to witness our government in action. So welcome to today's committee hearing. And our first bill that we'll hear is House Bill 1596 with Delegate Clark. Oh, I'm sorry, Delegate Clark. 1 moment, please. We do have an administrative action item. By the request of the patron, we will ask that House Bill 1906 be tabled and ask that the chair of the Health and Human Services Committee write a letter to the Department of Social Services and the Virginia Department of Health to study this issue.
So moved. Second.
Thank you. It is a recorded vote, and Madam Clerk will open the roll. All right, and that bill will be tabled by a vote of 7-0. All right, thank you, Delegate Clark. House Bill 1596.
Good afternoon, Madam Chair and members of the subcommittee. I do have an amendment for this bill.
Would you like to explain the amendment, or would you like counsel to explain?
If counsel could.
All right.
Madam Chair, this is an amendment in the nature of a substitute. The original bill was changing the definition of telemedicine services for the entire statute, which is where we have our state plan for medical assistance services. This changes it to just add a provision for the payment of medical assistance for real-time audio-only telephone when authorized and in compliance with federal law and delivered to a patient via audio-only means when no other means of one-time two-way or real-time two-way audio-visual or other telecommunications is available or operational to the patient, and the patient does not have the capability to use that type of communication.
Counsel, could you please remind us if that is an amendment or a substitute?
Madam Chair, that is an amendment in the nature of a substitute, so substitute.
Move the substitute.
All right, all those in favor, please say aye.
Aye.
Any opposed? All right, the bill as substituted is now before us. Delegate Clark.
Chairman.
Oh, yes, Delegate O'Rourke.
Yeah, quick question. This is Chandler. So if I understand correctly, long and the short, the audio is only allowed if a video telemedicine is not available, to kind of cut to the chase, correct?
Mr. Chair, that is correct.
All right, thank you.
Delegate Clark.
Thank you, Madam Chair. Today I'm introducing HB 1596. This bill would add audio-only telehealth services to the list of medical services that are covered by Medicaid. This would reflect similar language that was included in the 2025 physician fee schedule released by the Center for Medicare and Medicaid Services that allowed for these services to be covered by Medicare. Audio-only telehealth services are for cases where patients are either incapable or do not consent to using video technology. Audio-only telehealth services are a critical step towards addressing inequities in our healthcare access. People with low income, members of minority groups, and those living in rural areas often do not have the same access to healthcare and medical service either in person or over video call, and may only be able to access these services via audio only. So this legislation will mark a significant development for rural patients who are often have less access to broadband internet compared to those in urban places. And some of which may only have the ability to use audio-only telehealth service. I do urge the members to support this bill. Thank you, Madam Chair.
Thank you so much, Delegate Clark. Are there any questions from committee members? Okay. Are there any folks in, oh, sorry, Delegate Henson.
Quick question, is there a fiscal impact on this?
Yes, this does have a FIS.
Okay, great. Thank you. Are there any questions? I'm sorry, there are no questions from the audience. Are there any folks in the room who would like to testify in support of this bill? Good afternoon. Welcome.
Thank you so much, Chairwoman Tran, members of the House Health and Human Services Social Services Committee. I'm Dr. Karen Ruban, a pediatric cardiologist at the University of Virginia, director of the Center for Telehealth, board chair of the Virginia Telehealth Network, and a board member of the Medical Society of Virginia, also a past chair of the Board of Medical Assistance Services. We extend our sincerest gratitude to the House Select Committee on Advancing Rural and Small Town Health for its work this past year. We express our strongest support of House Bill 1596, a provision for payment for medically necessary healthcare services provided via audio-only technologies with a substitute language when no other means of real-time two-way communications is possible. Audio-only services adopted during the public health emergency proved to be a lifeline for many patients and has sustained their continuity of care and mitigated disparities faced by many Virginians who even today still lack access to broadband services or who don't have the ability to conduct a video visit. Medicare has permanently added audio only to its covered services, and therefore we strongly support this bill. Thank you for your consideration.
Thank you so much. Good afternoon.
Good afternoon, Madam Chair. Davis Gammon with the Virginia Hospital and Healthcare Association, and we support the bill and thank Delegate Clark for bringing it. We'd associate our comments with Dr. Ruban. I think this will be a game changer, and particularly in rural communities, and providing access to critical primary care in particular. So we hope you'll advance it to the full committee. Thank you so much.
Thank you. Are there any folks in the room here to speak in opposition to this bill? All right, I don't see anyone, but I do believe we have an online witness. Ms. Teresa Champion. Teresa, you're up if you can hear me. Teresa, I think you're still on mute. There you go. If you can turn your video on, please. There you are.
Thank you for your patience. I'm sorry for the delay. The Virginia Autism Project supports this bill. Thank you very much.
Thank you. All right. Committee members, are there any questions? Okay. If you would like to make a motion, we would need to report the substitute and refer to appropriations.
Move to report and refer as substituted to appropriations.
Second.
Okay, there's been a motion. It's properly been seconded to report and refer the substitute to appropriations. Madam Clerk, if you can open the roll. Okay, great. And this bill moves on by a vote of 7-0. Thank you so much, Delegate Clark.
Thank you, Madam Chair, members of the subcommittee.
Great. I will ask Delegate Laufer to come up next, please. Committee members, we have House Bill 1975 before us.
Thank you, Madam Chair and members of the committee. HB 1975 is a recommendation by the House Select Committee on Rural Health Care. It seeks to expand access to health care, reduce costs, and improve outcomes for patients. And this bill will help the Commonwealth align with the federal payment plans currently in existence. 1975 takes an important step to expanding telehealth in 3 ways. First, an e-visit. An e-visit, again, is already covered by Medicare. It's a patient-initiated request, and I'm going to get really technical here, for an asynchronous appointment for a low acuity problem within the context of an existing provider-patient relationship. So this is like you contacting your doctor about an issue you're having. So again, it's only with existing patients, and this is to improve access and timeliness and convenience for patients. And already this is being covered by Medicare, and we're asking that we cover this in Medicaid as well. Second is an e-consult, which is, again, covered by Medicare since 2019. And doctors actually were able to get reimbursement from this back in 2012 when there was a grant. So this is a provider-to-provider consultation. So this is your doctor calling a specialist for a second opinion on your behalf, and the specialist is giving written recommendations to your doctor that are then communicated to you as the patient. And this would allow both the specialist and the healthcare provider to receive a reimbursement. It's a reduced reimbursement, but it's identifying the work that they're doing. And again, this is a low-cost way to improve outcomes and improve access. And the last way is similar to Delegate Clark's bill, which is the audio-only service. This is also covered in Medicare, and this is a scheduled visit with the patient. So you've already called your doctor, you're gonna have this appointment, but because you might not have access to broadband or you don't know how to do the video appointment, that you would be covered as an audio-only appointment. And I want to just say, I grew up in a very rural area. This is a game changer. You know, my mom, we had 8 kids in the family, and actually when we went to the doctor, my mom just took all of us. So hopefully we could all just be seen at the same time. So, you know, I know the barriers we have with, you know, getting to the doctor and then waiting, and, you know, so this will really improve outcomes. And I hope it's the will of the board to report.
Thank you so much, Delegate. Are there any questions from our committee members? Delegate Henson?
Thank you, Madam Chair. Quick question. Is there a fiscal impact?
Yes.
There is. This bill would have to be reported to appropriations, or referred to appropriations if we move forward.
Thank you.
All right. I don't see any other questions from our committee members. Are there folks in the audience who'd like to speak in support of House Bill 1975? Good afternoon, Doctor.
Thank you, Chairwoman Tran and members of the committee. Dr. Karen Ruban again. We thank the patron, Delegate Laufer, and the Select Committee. E-visits in most cases prevent an in-person visit. These have been covered by Medicare and many commercial insurers since 2020 and are reimbursed with specific guardrails that prevent overutilization and duplication of services. You've learned about e-consults as well. 85% of patients who received an e-consult did not need to have an associated specialist visit in the ensuing 6 months. Medicare is permanently covered, as you've heard, since 2019, and national Medicaid has approved e-consults as a covered service. I urge the committee to extend this critical service to our own Virginia Medicaid beneficiaries. Thank you so much.
Thank you. Are there any other folks in the room to speak in favor of this bill? Are there any folks who are here to wish to speak in opposition to this bill? All right, it's back with us, committee members. Are there any questions for the delegate? Okay, so like we said, if we'd like to move this bill forward, it would need to be referred to appropriations.
Move to report and refer to appropriations.
Okay, so we have a motion that's been properly seconded to report and refer House Bill 1975 to appropriations. Madam Clerk, if you can please open the roll. Great, thank you. And you're moving on by a vote of 8-0. All right, Delegate Tata. We have House Bill 1964 before us.
Thank you, Madam Chair and members of the committee. I have a substitute, and I also have another substitute, kind of 2 substitutes. One should already be printed, and one is council.
Would you like council to report the substitute, plural?
Yes.
Thank you.
Thank you, Madam Chair. So the first substitute establishes the Bright Futures program as a program that provides case management services and a stipend payment to program participants. So this is a more limited program than what was provided in the introduced bill, which basically created a state-level extension of the existing Fostering Futures program. So this scales it back to just be case management services and a stipend payment. The substitute also removes the requirement that a hearing be held whenever a program participant enters into a program agreement. And Yeah, it's open to individuals aged 21, 22, and 23. So that is substitute number 1. Substitute number 2 changes the name from Bright Futures Program to Futures in Focus Program. Yep.
Madam Chairman, parliamentary inquiry.
Delegate Orrock?
How can we have 2 substitutes? We can fold them both together into one or something, but you can't. So could staff help me on that?
Madam Chair, yes, we can roll them into one. Into one substitute.
Can I just ask if is that the substitute that's printed on LIS now?
Madam Chair, the first substitute I described, where it lays out this new program that provides case management and a stipend payment, that is what is live online. So what we would be doing that's not available online is just changing the name from Bright Futures Program to Futures in Focus Program.
So maybe we can move the first substitute and then amend it. Can we have a motion to move the first substitute?
So moved.
All right, all those in favor say aye. Aye. Thank you. And then we have an amendment to this substitute to change the name of the program.
So moved.
All those in favor say aye. Aye. Any opposed? All right. The substitute as amended is before us. Delegate Tata.
I appreciate that. And just to explain that second substitute, Madam Chair, is the foster youth actually picked the new name. So we had to throw that in there. So thank you for indulging me. So as introduced, HB 1964 mirrored the language of Fostering Futures, but changed the age for program participants from 21 up to 24, 20 through 23. And while it captured the essence of my desire to offer support beyond the age of 21, the bill would have categorized the program as foster care and required court involvement. So now the new bill establishes the Future in Focus program, which provides essential support and resources to individuals aged 21 up to 24. The fundamental purpose of the Future and Foster program is to assist participants in transitioning into adulthood, achieving self-sufficiency, and establishing lasting positive relationships. Future in Focus is a voluntary program for individuals aged 21 up to 24 who live in the Commonwealth of Virginia. They've participated in Fostering Future programs before turning 21. They've completed either secondary education or vocational training and worked at least 80 hours per month. Each participant will be assigned a case manager with DSS and receive a stipend. This individualized framework promotes consistent support and stability to help ensure that all young adults in Virginia receive the resources and opportunities they need to thrive. Unfortunately, Virginia ranks near the bottom among U.S. states regarding outcomes for youth in foster care. Many do not graduate from high school or obtain a driver's license. 20% of foster youth experience homelessness immediately after aging out, and after 18 months, that percentage rises to 40%. These statistics highlight the need for continued support and intervention because without it, these youths are left vulnerable to gang activity, incarceration, or human trafficking. We acknowledge that the average maturity of a healthy prefrontal cortex reaches around age 25. Youth in foster care frequently encounter varying degrees of trauma that can postpone this maturity, leaving them unprepared at 21 to thrive without a support system. I work closely with DSS and stakeholders on this bill, and I hope you will support it. And it does have a fiscal impact.
It does. All right, thank you so much, Delegate Tata. Are there any questions from our committee members about this program? It's similar to a bill we heard last year as well. All right, are there folks in the room today who'd like to speak in favor of House Bill 1964? Great, here's some folks. Thank you so much.
Good morning. It's not morning anymore.
Good morning. Good afternoon.
Committee. Allison Gilbreth, Voices for Virginia's Children. We support this bill and thank the delegate for bringing it forward. Thank you.
Great. Thank you so much. Are there other folks in the room? Come on forward.
Well, thank you for hearing me today. My name is Mark Stevens, and I'm with Stand Up for Kids, who work with our homeless youth in Hampton Roads. I've been doing this for 18 years, a volunteer. I'm a father who adopted a 14-year-old out of the foster care system who came to me at 14 at a third grade level after being there his whole life. We need to do something better for these youth. For years, I've been trying. At 18, my son thought he had to move out after he was adopted. I had to explain to him, no, you've been adopted. You get to stay with me as long as you want. He's 32 now. But we need to help these kids. We've been rated the worst since I adopted him, and we are a better state than most, and we need to do something for these kids. We can't continue to do this. So I beg you to change what we're doing and make it better for these young people. Thank you.
Thank you for sharing your family's experience. Good afternoon.
Good afternoon, Madam Chair. Valerie LaRue from Virginia Poverty Law Center, and we're very appreciative of Delegate Tata bringing this bill. We very much support this and providing those kinds of assistance to youth as they transition into adulthood. I just want to note that federal bill that just passed on the federal level does allow states to draw down federal funds to assist foster youth in this situation up to age 26, which is a change in the federal law. So I'm hoping that doesn't go into effect until October. So I'm hoping that perhaps next year we can expand it to youth up to age 26 because as a mother of a young adult who is in that age range, I know that they still need those kinds of support. So thank you.
Yes, thank you so much. Good afternoon.
Good afternoon, Madam Chair. Eric Reynolds, Children's Ombudsman. I support the bill. Thank Delegate Tata for carrying it. Thank you.
Thank you so much. I believe we have a number. Are there any folks in the room who'd like to speak in opposition to this bill? Okay, and I believe we have a number of folks who are here online to speak in support of this bill. So I'm going to call your name, and if that's you, please come off mute. I have Mrs. Joy Rios.
Hello, everyone. Thank you for having us here today. Thank you, Delegate Tata, for carrying this bill. I am the Executive Director at Connect with a Wish. We're a nonprofit that benefits local youth in foster care, and we spend most of our time and funds on the many needs for the aging out population. We firsthand see the need for this bill, and we hope that you will all pass. We are in great favor. Thank you.
Thank you so much. Layla Estrada? Okay. David Bilheimer?
Good afternoon. My name is David Bilheimer, and I'm currently a foster youth participating in the Foster and Futures program. And through the programs, I've created my own bakery. I'm pursuing a business administration at Brightpoint and planning to transfer to JMU in the summer. And the programs such as Foster and Futures, Great Expectations, Project Life, and CEO through Workdays, they've been significant with supporting me through my journey through the foster care system. And adding this bill would benefit a few extra years. Because four-year university, I'll be in there till I'm 21, and when I'm 21, I'm cut off basically. So this bill would be very supportive for foster youth.
David, thank you so much for sharing your personal experience with us, and good luck with your bakery. Stephanie McVicker? I can't see. Okay. Mr. J.W. Taylor?
Yes, good afternoon. Thank you for allowing us to present. I'm J.W. Taylor. I'm the Great Expectations coach at Virginia Western, and I work directly with students every day that are in the Foster Futures program as it is. I've got this whole group here because I just wanted to introduce you to a couple of the students. Both of the gentlemen to my left and right are both turning 20 within the next couple of months, with Kevin here turning 20 in 2 weeks. 21. So they're students that are directly going to be affected just by aging out of that Foster and Futures. They are both bright students. They've both worked really hard to get a club off the ground. We've done charity work. They're doing great work here. But it's going to be a challenge for them to continue to do their education and work without the support of this bill. I appreciate your time. Thank you.
Thank you so much. Really appreciate y'all being together and joining us today. All right, I think that were all of our online witnesses. So if this bill moves forward, it needs to be referred to appropriations.
Madam Chair?
Yes.
Move to report and refer as substituted to appropriations.
I think we're okay? Okay, yes. And that motion was properly seconded, and the substitute is now before us. If Madam Clerk can open the roll. All right, passes out unanimously. Thank you so much, Delegate Tata. I'm going to ask Delegate Sullivan to come up so that he can go on to chair his subcommittee too. Delegate Sullivan.
Thank you, Madam Chair, and good to see you all.
rule number one in this body is never fall in love with your bills. But I always fall a little in love with bills that are brought to me by young people. Gives them a chance to see that they can actually affect change and be part of a process, a democratic process, and get bills through something like the Virginia General Assembly. I hope Mr. Taylor and his team's still on the line, because this bill came to me through some students at the Great Expectations Student Success Program at the Virginia Western Community College, where you just heard from, and they were engaged in an advocacy workshop. And one of them commented, when the issue of the existence of the ombudsman came in, and I think the ombudsman is even here in the room, that they never knew there was an ombudsman. And the discussion went on, and they brought to me the important realization that a lot of kids in the system don't even realize that there is a youth ombudsman. And so this very simple bill simply requires that every kid, once he or she turns 12, and every year after that, if they're still in the foster care system, be told there is an ombudsman. If you need help, if you have something you need to talk about in terms of your situation, here's how to get in touch with the ombudsman. And makes very clear, because some of these kids are worried about confidentiality and such, that they can call the ombudsman without fear of any kind of retribution or retaliation. So it's a simple bill, but I hope that it will make a difference for some kids who might have an issue they need to talk with the ombudsman about. This will make them aware of it and hopefully improve their lives. And it comes from the people who are telling, through me, they are telling you that they think this will help them and their colleagues in the system.
Thank you so much, Delegate Sullivan. Are there any questions from committee members? All right, I don't see any hands up. Are there folks in the room who'd like to speak in support of the bill? Here we go.
Thank you, Madam Chair. Valerie LaRue from Virginia Poverty Law Center. We also support this bill. I, along with Voices for Virginia's Children, do an advocacy workshop with youth in the Great Expectations program every year. And this bill did come, as Delegate Sullivan said, from the youth at Virginia Western Community College in Roanoke. Delegate Austin and Delegate Rasul are co-patrons in this bill as well. And hopefully they'll have the opportunity, those youth that you saw earlier, will have opportunity to speak to this bill as well. Thank you.
Great, thank you.
Madam Chair, members of the committee, Allison Gilbreth with Voices for Virginia's Children. We strongly support this bill. On an average week, I typically receive 3 to 4 emails from young people looking to make a complaint of this sort, and they don't know about the Children's Ombudsman Office that they can make a complaint to. So this would go a long way, especially for helping our young people who are in congregate care settings in Virginia. Thank you.
Great, thank you so much. Hi again.
Good afternoon. Eric Reynolds, Children's Ombudsman. I support the bill. I appreciate Delegate Sullivan carrying it on behalf of the participants in Fostering Futures and Great Expectations that we saw. It does provide some important clarifications for me and for my office, and able to assist those participants in the Fostering Futures program. Also affords them the confidentiality that we provide adult complainants. We can afford the same level of confidentiality to kids in foster care and the Fostering Future participants when they contact us as well. So appreciate it and support the bill.
Great. Thank you. We have a couple of questions from committee members. Delegate Gardner.
Thank you, Madam Chair. I have a question for Mr. Reynolds.
Go ahead, Delegate.
Hi, how you doing?
Good. How are you doing?
Is this an extension of the bill that I carried for you guys last year that allowed you to talk to the children, and this one allows the children to talk to you?
It does expand upon what, Madam Chair, I answered the delegate, that it does expand upon what your bill did last year and make some important clarifications that we didn't cover last year.
Great. Thank you so much. Delegate Singh.
I've heard the term ombudsman in other contexts, but I'm not sure how it works here. So if someone who's 13 years old has an issue with the family they're placed with, they go to the ombudsman. Is that how that works? And is the consultation confidential? Could you describe the mechanics of this?
Madam Chair, I'd answer delegate that we do receive complaints from the general public
The original statutes, as they currently exist, allows children to contact us and submit a complaint that we can look at cases involving children who are receiving child protective services or who are in foster care. Whatever the issue is, we can take a look at, make sure that the system is working properly for everybody involved, especially the children, making sure that the local agencies that are involved are following laws, rules, and policies. And so those are the kinds of issues that we would look at on behalf of the children that contact us as well as the adults.
All right, great, thank you. Are there any other questions from our committee members? Okay. This bill does not have to be referred to appropriations if you'd like to make a motion.
Madam Chair, I move that we report HB 1777.
Second. Delegate Gardner, I'm proud to stand on your shoulders.
Thank you.
All right, the motion has been made and properly seconded to report to recommend reporting HB 1777. Madam Clerk, if you can open the roll. And the bill moves forward on a vote of 8-0. Thank you, Delegate Sullivan, for helping carry those youth's voices forward.
Thank you, Madam Chair, members of the committee.
Great, thank you. I'd like to call Delegate Feggins up. Members, we have House Bill 2102 in front of us.
Good afternoon, Madam Chair. I believe there could potentially, is there an amendment? Okay, it did not come down then. Okay. Good afternoon, Madam Chair and members of the committee. Thank you for the opportunity to present House Bill 2102, Presumptive Eligibility for Pregnant Women, a crucial initiative to establish presumptive eligibility for pregnant women in Virginia. This legislation ensures that pregnant individuals will have access to timely prenatal care, bridging a critical gap in our healthcare system. With presumptive eligibility for Medicaid being introduced in 1986 to address disparities in healthcare access for uninsured pregnant women, it allows immediate temporary Medicaid access based on preliminary income eligibility. Research has shown that access to early prenatal care improves birth outcomes and reduces complications. The implementation would be that under HB 2102, we would seek federal authority to establish presumptive eligibility for pregnant women in Virginia, authorizes and train qualified entities, including healthcare providers, and also provide oversight to ensure compliance, prevent fraud, and monitor the effectiveness of the program. Qualified entities would assist with individuals with completing full applications within 30 days to ensure a smooth transition of presumptive full eligibility. The program assumes that around 6,000 annually would be presumptively enrolled based on 2022 birth rates. The average cost per person would be around $1,111, growing at 5% annually, and DMAS estimates that the total cost would be around $4.5 million from the general fund in FY26 and $4.4 in FY 2027. Madam Chair, as part of our omnibus legislative package, we aim to improve the maternal and child health care outcomes in the Commonwealth, and I urge the committee to favorably report.
Great, thank you so much. We have a question from Delegate Orrock.
Thank you, Madam Chairman. So Delegate Figgins, how would this actually work when the mother presents, at what juncture, and just explain from the nuts and bolts from the mother's perspective how she would know she's eligible for this, how that would work through, if you would, please.
So yes, so there's currently, in terms of options, in terms of for a pregnant woman being able to apply online, to call on the phone, I would ask that if there's DMAS individuals, as I've not actually done this myself as a former medical administrator, if DMAS or someone was here to be able to explain the exact way that happens. So
you would like DMAS to come up?
If they're available,
yeah,
yes.
I think that Will is, oh, here we go. Wait, oh, there we go. Hello, sorry. I thought you pointed to Don Sleeman, and I was like, oh, hello.
Good afternoon, Madam Chairman, members of the committee. Sarah Cariano with DMAS. How this works is traditionally when someone would like to come in for Medicaid, they come in through the portals, they apply, we process the application. Per state code, pregnant-related applications are required to be processed within 7 days unless there's additional information that's required. All applications are required to be processed within 45 days, with a small exception for individuals who need a determination of disability. With presumptive eligibility, and we have hospital presumptive eligibility in Virginia right now, so this would be in addition to that. The individual would come in and the qualified entity would say, okay, we think based on your attestation of your income and the other factors of eligibility that you are eligible for Medicaid. That person would be enrolled in a limited benefit package. So the federal rules do state that a pregnancy-related presumptive eligibility covers ambulatory prenatal care only, so it's limited for that period of time. The individual would then have to submit a full application for that full ongoing coverage, and that would be processed within the standard timelines. Presumptive eligibility lasts until the end of the month following the month of application. So if I apply today, the longest I could be in a PE period is until the end of next month. And so, I would need to apply and get it processed, and then the full application hopefully would be approved. Do you have other specific questions about kind of the implementation?
Delegate Orrock, do you have a follow-up?
Yeah, just follow up to that. So during this presumptive eligibility period, if they're later determined to not be eligible, there's no kind of clawback or anything. It's just they were covered during that time, and then the benefits from the state stop.
Right.
At that juncture was determined they're no longer compliant.
Right. So within the Social Security Act, there's language that says basically presumptive eligibility. If the person is not eligible, there's no clawback from the Fed, so there would be no clawback from us, from the provider or the member. But we'd have to do auditing and stuff to make sure the providers are doing it properly.
All right, thank you. I have a question from the Uber chairman, Delegate Sickles.
Thank you. Sarah, could you just mention what examples of a qualified entity that might be eligible if we pass this?
I believe they were delineated in the bill to some extent, at least the one I read. I don't know if there was a substitute, sorry. So essentially there's a list within the federal regulation that says it could be any of these or an entity identified by the state. And so we can really, the rules are very, very broad. The impacts of who is a qualified entity would obviously be different. So if we were to contract potentially, if we were directed to enroll qualified entities that were not healthcare providers and already subject to HIPAA or already in relationship with DMAS, with data exchange agreements and stuff, there would be kind of different implementation costs associated with the different systems needs. But right now we work with hospitals, and so we do have the system for our currently enrolled providers.
Mr. Chairman, it looks like it could include healthcare providers, community-based organizations, elementary or secondary schools, or some examples.
Madam Chair,
yes, Delegate Sickles.
So you would enter into a different type of agreement based on what kind of organization they are. Is that right?
I think it would be the same agreement, but to some extent, just thinking through the requirements for keeping information secure that we have to abide by, the rules that the other entity already has to abide by would kind of impact. So a community-based organization perhaps doesn't have all the security features in their data management systems that a hospital does. And so that would just be taken into account as we were working through the process.
Thank you, Madam Chair.
Thank you. Delegate Henson.
Thank you, Madam Chair. Question for the patron. You talked about numbers. I just want to confirm it does have a fisc impact, yes?
It does have a fisc.
Thank you.
Great. Thank you. Delegate Orrock.
Yeah, Madam Chairman, my apologies. If you could come back up. So I want to make that kind of following up with the Uber chair. So the qualifying entities, we've got performance standards for them. So what happens to the mother when she's eligible for these services, and the entity, because they don't turn in the paperwork to 95%, 90% as said here in the legislation, what happens to the care that she needs to receive?
So there would be no impact on someone who had already been enrolled through this process for that individual, but this DMAS would be able to kind of remove the status of qualified entity from that entity, so they would no longer be able to do presumptive eligibility going forward.
Okay, Madam Chairman.
Yes, Delegate Orrock.
So to that point, they would continue with that medical care provider as long as they needed, but that provider would then be removed from the list for future treatment of patients.
I will have to confirm this. So their certification with DMAS to provide medical care and be a certified provider within Medicaid or credentialed with the MCOs is separate than their status as a qualified entity. And so they may still be able to, they would still be a provider, they just wouldn't be able to do presumptive eligibility enrollments for their patients anymore.
And Madam Chair, one final. And y'all don't
Delegate
see a
O'Rourke.
challenge with the 95% compliance standard that's written in the statute?
And I'm sorry, could you repeat that?
Yeah, y'all don't anticipate a problem with the respective 90 and 95% compliance standards set in the statute for the entities in their reporting?
Madam Chair, I would state to the
Delegate
delegate
Figgins.
that one of the reasons in terms of the current fiscal impact was actually revised is that that this would be adding in 9 additional FTEs to be able to support the management of the program and to make sure that fraud, waste, abuse, and the management to be able to help out is taken care of.
Great. Thank you so much. Are there any folks in the room who'd like to speak in favor of this bill? Oh, I see some movement. Hi.
Hi, good afternoon, Chair Tran and committee members. I am Catherine Haynes with the Virginia Interfaith Center for Public Policy, and we would like to thank Delegate Figgins for bringing forth this important bill, HB 2102. I would also like to thank the PUSH Coalition for their work supporting this bill. The coalition is made up of 43 organizations, and this is one of our 4 priorities that we are supporting as a coalition this year. In 2024, we focused our expansion on rural areas, including the Dan River Region Maternal Health Task Force, the Health Collaborative, the Infant Maternal Health Coalition in South Boston, the Maternal Health Task Force of Martinsville-Henry County, the Tri-City County Community Action Agency, and the Virginia Rural Health Association. The areas represented by these groups have some of the worst infant outcomes in the state. For example, the Black infant mortality rate in the West Piedmont Health District in 2022 was 35.5 per 1,000, while the rate was too small to report for the white or non-Hispanic population. We need this bill to do better. Thank you.
Thank you so much. Good afternoon.
Good afternoon, Madam Chair, members of the committee, Allison Gilbreth, Voices for Virginia's Children, and we support this bill.
Thank you. Good afternoon.
Good afternoon, Madam Chair, members of the subcommittee. My name is Victoria Richardson. I'm an attorney with the Virginia Poverty Law Center. First off, thank you to Delegate Figgins for bringing this important bill. We're in support of this bill because we're in support of lowering administrative barriers to care for pregnant individuals. Thank you.
Thank you. Good afternoon.
Good afternoon, Madam Chair. I am Olivia Turner, the president of the Virginia Society of Human Life, and we do support concepts like those offered in Delegate Figgins' bill, because we do believe strongly that we're at a crossroads. We need to find whatever avenues we can to expand our ability as a Commonwealth to help mothers, to help their children, and to make our society stronger. Thank you.
Thank you so much. Hello.
Hello, good afternoon, Madam Chair, members of the committee. Chloe Edwards with New Virginia Majority. We serve working class people of color, in particular, work to improve the lives of women. Presumptive eligibility would close coverage gaps and improve outcomes, creating strong mothers and healthy babies. We ask that you support this bill. Thank you.
Thank you. Good afternoon.
Good afternoon, Madam Chair, members of the subcommittee. My name is Freddie Mejia from the Commonwealth Institute. We support this bill. We know that right now there's an expedited pathway for applications for pregnant folks, but that often doesn't get met, and a lot can happen within the 10 days that these applications are supposed to be met. So presumptive eligibility meets that gap. Thank you.
Thank you so much. Are there any folks in the room who wish to speak in opposition to this bill? Okay. Let me just see, number 2102. Okay, there's nobody online. This bill is with the committee. If it moves forward, it needs to be referred to appropriations.
Madam Chair.
Yes, Delegate Shin.
Thank you, Madam Chair. I'd like to thank the delegate for bringing a bill like this forward. I think we've seen a lot of bills this year that address maternal mortality and the care for pregnant people and health outcomes for infants. I'm really glad to see this, and I would make a motion to report and refer to appropriations.
Second.
There's been a motion to report and refer House Bill 2102 to appropriations, and that's been properly seconded. Madam Clerk, if you can open the roll, everybody can vote. We're doing such good work in this committee. Your bill moves forward on a vote of 8-0. Delegate Figgins, thank you so much.
Thank you, committee members.
All right, Delegate Rasool. And before us, we have House Bill 2597.
Thank you, Madam Chair. Members of the committee, House Bill 2597, which is before us, seeks to add some clarifying language around the issuance of a provisional license. So right now, What we have in the Commonwealth is licensure for a variety of facilities, including assisted living, adult daycare, and child welfare agencies. As you know, they have periodic inspections, and of course, sometimes they're inspected when there are violations or proposed violations that when those violations are significant enough, significant health and safety violations, the facility then is put on a status that says, hey, something's wrong here. We're going to put you on a provisional status. You're going to have a provisional license. And you need to hopefully come up with a plan of correction. You have 6 months. It can be extended to a year to correct those significant health and safety violations. And this happens on a very limited basis. There are only 5 facilities in the Commonwealth that have a provisional status right now. But sometimes they need to be given a firm warning because someone is at risk here. And so the bill that is before you is simply saying that if you have been put into the status, that it's clarifying that that is not some kind of appealable process. And so the bill, we also have a substitute that I would like to offer that offers some clarifying language.
Okay. Well, let's see. Can council report what's in the substitute?
Madam Chair, yes, the delegate was also speaking to the substitute as well. There was a drafting error that it was originally drafted as the denial of the issuance of a provisional license. This takes out the denial. This is just the issuance of a provisional license is not appealable. It also changes the statute that this is placed in. So instead of being in 63.2-1710, which is the appeal statute, this is placed in 63.2-1707. That's the issuance or refusal of a provisional or conditional license statute. Those are the changes.
Okay, so can we have move the substitute so it's properly before us, Delegate Shin?
Move the substitute.
Second.
All right, can all those in favor of moving the substitute say aye? Aye. Any opposed? Okay, the substitute is now properly before us. Delegate Rasool.
Yeah, thank you, Madam Chair. I think that describes it. What's key here is it's not, you still can appeal on behalf when there is an initial issuance or renewal or a revocation if there's some kind of issue. This doesn't touch that at all. It's just when there are significant health and safety issues.
Okay, great. Are there questions from our committee members? All right, are there folks in the room who wish to speak in support of this bill? Good afternoon.
Good afternoon, Madam Chair, members of the committee. My name is Tara Ragland. I'm the Division Director for Licensing Programs. We have a support from the governor on this bill.
Great, thank you. Are there any folks in the room who wish to speak in opposition to this bill? All right, I don't see anybody. Let me see. Is there anybody online? I don't think so. There's nobody online for this bill. Committee members?
Second.
All right, there's been a motion to report that's been properly seconded. To report the substitute, it's been properly seconded. If we can please open the roll. Delegate Rasool, your bill moves forward on a vote of 7-1.
Thank you, Madam Chair, members of the committee.
Thank you. All right, Delegate Willett.
Thank you, Madam Chair. Madam Chair, I have HB 1900 before the committee. This bill would allow what is called rapid whole genome testing or sequencing coverage by DMAS for babies 1 year or younger when receiving inpatient care. This bill enables access to comprehensive genetic testing, including rapid whole genome sequencing for critically ill infants in a neonatal intensive care unit, a NICU, to help diagnose rare diseases early on. This will reduce what can be, for a lot of families, a very long and uncertain diagnostic journey for rare disease patients. In a nutshell, faster diagnosis, faster intervention that will save lives and actually save money as well. Folks know a lot more about this than me, can speak to this, but I appreciate the committee's time today. Thank you.
Thank you so much, Delegate Willett, on House Bill 1900. Are there any questions from our committee members? All right. Are there folks in the room who'd like to speak in support of this bill? Okay, I see some folks coming. Good afternoon.
Good afternoon, Madam Chair and members of the committee. My name is Ben King. I'm here to testify on behalf of my daughter, Olivia LaForte King. My wife's pregnancy was uncomplicated, but hours after birth, medical complexity sent Olivia to the NICU. We spent 6 weeks of agonizing unknown in two of the best hospitals in Virginia in a NICU environment. We consulted with very many specialists who ran every test that they could think of until we ran out of things to ask for and felt helpless. Finally, rapid whole exome sequencing, which is the same technology or similar technology to rapid whole genome sequencing, was ordered and provided an acute diagnosis within 5 days. Olivia was born with EEF 1A2 related neurodevelopmental disorder, a condition with roughly 100 confirmed cases worldwide. After the diagnosis, we aligned with the hospital staff and were streamlined to appropriate specialists. We had confidence in the care plan and could prepare for the future. Through the molecular diagnosis, Olivia qualified for Medicaid as an outpatient. She passed away peacefully in October 2022 in her mother's arms. The diagnosis had direct clinical value, immeasurable personal value, and immense financial value, both to our family and the overall healthcare system. The most difficult thing to reconcile about our NICU experience is how much time, emotional energy, and money was spent utilizing before utilizing the most comprehensive diagnostic tool available for medically complex, undiagnosed NICU babies who are the most vulnerable and innocent Virginians. Thank you.
Thank you for sharing yours and Olivia's experience and for advocating for other kids. Good afternoon.
Good afternoon, Madam Chair. Lauren Schmidt on behalf of Children's National Hospital. We are in DC, but we serve a lot of children from Northern Virginia, and we very much support this bill. Thank you.
Thank you so much. Are there any folks in the room who'd like to testify in opposition to this bill? All right. And I don't see anyone online. Members of the committee, or if you have any questions, and if this bill moves forward, it needs to be referred to appropriations.
Madam Chair, I have a motion.
Delegate Shin?
I move to report and refer to appropriations.
Second.
There's been a motion to report and refer House Bill 1900 to appropriations. It's been properly seconded. Madam Clerk, if you can open the roll. And your bill moves forward, Delegate Willett, by a vote of 8-0. Thank you so much.
Madam Chair, thank you. Thank you, the committee.
All right. Delegate Moorfield.
Good evening, Madam Chair, members of the committee. You have before you House Bill 1762. This bill would direct the Department of Medical Assistance Services to seek necessary federal authorization to provide Medicaid coverage regardless of income or assets to individuals who receive Social Security disability insurance but are not yet eligible for Medicare coverage. So healthcare policy is certainly not an area of expertise that I'm very familiar with, like many of you are on this committee, but I do know as lawmakers, we have an obligation to do everything that we possibly can to help those who are in need, especially when it makes common sense and good fiscal sense. And this is exactly why several years ago, I was the first Republican member of the House to publicly stand up and support Medicaid expansion. And as many of you know, Medicaid expansion has helped so many throughout the Commonwealth. And earlier I mentioned the fiscal sense. Medicaid expansion has been good for rural areas because it's kept so many hospitals open. And we all know that the closure of a hospital is devastating, not only from a healthcare perspective, but from an economic development perspective. And so in my opinion, and I know that after having conversations with a number of my colleagues, and here in just a little while at the chair's discretion, we'll hear from an individual who is seeking this very assistance, that there are a number of people that would benefit. In my opinion, this would serve as a common sense and good fiscal sense investment from the Commonwealth. We do have a gentleman, Mr. Kelly Queen, and his wife today will speak on behalf of Mr. Queen. At the time, he was 48 years old. After contracting COVID, he succumbed to a brain aneurysm. He was very productive. He went to work every day to provide for his family, and now his wife has to take care of him. There is a significant fiscal impact to this bill, but once again, look at the impact that many of those who are living in this situation, it will have on their lives and their children's lives, when many of those caretakers will have to quit their jobs to take care of those who are no longer in the position to take care of themselves. And with that being said, Madam Chair, I'll be happy to take any questions and look forward to listening to the testimony of Mr. and Mrs. Queen.
Great. Thank you so much, Delegate Moorfield. Are there any questions from our committee members? All right. I don't see any yet. Are there folks in the room who would like to testify in support of House Bill 1762? All right. Are there any folks in the room who'd like to speak in opposition to House Bill 1762? Okay, so we're going to go to our online testimony. I'd like to call on our iPhone 99, which I believe is the Queen family. Mr. and Mrs. Queen, can you hear me? There you go.
Yes, ma'am, I can hear you.
Okay. Are we?
Are you able
to?
There you are. Go ahead.
Yes. I appreciate the time today to come before you and for you all to listen to this, because I just like to stop and tell you the story. I wouldn't wish the experience that I've had on anyone or my worst enemy, and I'm ashamed to say that we have such a dip and such a deficit in the Commonwealth system. I'm a public school teacher and I teach government. So this has been a great learning experience for my kiddos. But that being said, I still found a big hole. And unless you recognize the issue, you can't fix it. That's what I always tell parents when they come to a parent-teacher conference, that unless I tell you what the issue is, you can't fix it. My husband's master's degree level educated. I have an EDS level of education. I'm a smidge nervous, but here's the bottom line. In the Commonwealth of Virginia, you must be disabled for 24 months if you are not 65. You may not obtain Medicare until you are 65, unless you have disability awarded to you for 24 consecutive months. Well, that's all well and good. My husband has a phenomenal job, master's level pay, et cetera, et cetera, et cetera. So we now are in a position to pay for COBRA because he's intubated. He cannot physically go to work. I exhausted every PTO day that the man had for 28 years, every sick day, every hour, everything, until finally we had to go to COBRA, and that was $2,000 out of pocket and $78 for dental. So it was about $2,100 expense each month. And you can only keep COBRA for 18 months. And so here we are, worked our entire lives, and he's had so many days accrued because he never missed, that I was able to go for about 4 months on PTO time and live as normal. Thank God. But that being said, I'm not getting paid. He's not getting paid. He's obligatory to child support per court order that I'm trying to have changed for his previous marriage. We also have become really accustomed to food and electricity. I can't get Medicare for him, and I can't put him on my insurance because of his pre-existing conditions. They has
Madam
refused
Chair.
it, and so I can't get Medicaid.
Madam Chair.
So I had to relinquish everything to get the Medicaid, and I just don't want to see this gap in the Commonwealth.
Mrs. Queen, thank you so much for sharing yours and your husband's story. And when my, I am very empathetic to the struggle with COBRA when my husband was laid off, and this idea of having a potential health insurance gap and how expensive COBRA was extremely stressful to our family as well. Thank you for being here to share your story. Delegate Singh, did you have your hand raised or your speak button? You're okay. Ms. Champion.
Thank you, Madam Chair. I again apologize for a problem earlier, but I wanted to also thank the patron for this bill. This is very important. I'm Teresa Champion with the Virginia Autism Project, and this would also benefit families who are on the wait list, the Medicaid waiver wait list. These individuals who have SSDI, we know will be receiving Medicare, and they will be eligible for Medicaid. So we need to fill this gap. And I personally also have had to get COBRA to fill that gap. So families are experiencing this now, and especially families who are on a Medicaid waiver wait list. Thank you so much.
Thank you. Delegate Shin.
Thank you, Madam Chair. I wondered if I might ask a couple of questions.
Yes, ma'am.
Madam Chair, I was wondering am I understanding correctly that a person has to be on SSDI for at least 24 months before eligibility for Medicare?
Yes, that's correct.
Okay. And so when I'm looking at the FIS here, Delegate Moorfield mentioned that there's a pretty large FIS, but in reading through the FIS, it seems like DMAS is saying that there's a projected population of 12,000 SSDI recipients in Virginia, and they assume 95% of utilization in order to get to this number. And that seems like a really high assumption of 95% utilization. And I wondered if DMAS could speak to how they landed at this number.
Will or somebody from the team, can you come up? Great, good afternoon.
Madam Chair, Will Frank with DMAS. I don't know that I have the answer to that. The Department of Planning and Budget issues the fiscal impact statements, so that I don't know how if I could speak to the development.
Okay.
Delegate Shin, do you have a follow-up?
Yes, Madam Chair, I would say thank you, Mr. Frank, for saying that. I think I would be concerned that this FIS is maybe an inaccurate representation of what it might actually cost to cover this population, because I wouldn't assume that all 12,707 people would be eligible within the 24 months for Medicare and that we were covering the entirety of that population. And even at 95%, I wouldn't think that to be true. And so if possible, I'd love to get a better analysis of what the actual cost might be and a better understanding of how many folks would be eligible. It seems like that's a number that could probably easily be deduced from based on timelines of people coming on, right? And at that appropriate time, Madam Chair, I'd have a motion.
Thank you, Delegate Shin. To the patron, Delegate Moorfield, that might be some avenues to pursue if your bill is referred forward. If you are planning to make a motion, Delegate Shin, this bill does need to go to appropriations.
Yes, Madam Chair. I would move to report and refer to appropriations.
All right, so there's been a motion. It's been properly seconded to report and refer House Bill 1762 to appropriations, and maybe you can have that conversation with the planning office. Delegate Moorfield, please open the roll. Madam Clerk. All right, your bill moves forward, Delegate Moorfield, by a vote of 7-0. Thank you so much.
Thank you, Madam Chair. You all have a good evening.
Have a good evening. Thank you. Next, I'd like to hear from Delegate Carlson.
Thank you, Chair Tran.
Delegate Carlson, before you come up, though, I think we also have a bill that is similar. So if you don't mind, Delegate Kilgore for House Bill 2209. I would like to incorporate House Bill 2209 into House Bill 2610, if we can get a motion for that.
So moved.
All those in favor say aye.
Aye.
All right, and Delegate Kilgore, if you would like to make any remarks, I'd like to give you an opportunity to do so.
I appreciate the delegate letting me hang around and help on this bill, and it's a very important issue, and I hope that the committee acts favorably. So thank you.
Thank you, Delegate Kilgore. All right, so before us, we now have Delegate Carlson's 2602 as a substitute because it's been incorporated. I'm sorry, 2610 as a substitute as it's been incorporated. Delegate Carlson.
Thank you, Chair Tran, and thank you, members of the committee, for giving me the opportunity to present this bill. At its core, this bill is a measure to protect our pharmacies. It is a bipartisan effort, as you just heard, and I'm thankful for the support of many of my Republican colleagues, as well as many Democrats who have reached out because they know that this issue is affecting their community. And before I get into the meat of the bill, I will say I was drawn to it because as a mother, I can't imagine living in a county. There are 5 counties in Virginia right now that don't have a single pharmacy in them. I can't imagine living in a county and knowing that I needed to get medicine quickly for my child and having nowhere to go. So that's why it was important to me. And I'm not alone. So 5 counties, no pharmacy. 15 additional counties have only 1 pharmacy in them. In addition to that, we know that, I imagine we all know that there's rising drug costs for all of us. And these pharmacies that are in existence, these local pharmacies and independent pharmacies, are often not reimbursed under our PBMs at a rate that allows them to continue in business. And this has created, according to the VCU study from last year, what are called pharmacy deserts. And those deserts disproportionately affect communities. Well, actually, they affect urban and rural areas alike. That's one of the reasons why this can be so bipartisan. They disproportionately affect vulnerable populations, so low-income people, racial minorities, and Medicaid communities. So how we're trying to tackle this, and I have one more personal story. I don't normally share personal stories, so hopefully y'all will indulge me. But I myself got sick earlier in session. I realized there was a doctor downstairs. I didn't realize that you go to the basement, go to a doctor. And I needed medicine right away. And I was scrambling because I'm like, I need to get this medicine before I go to floor. And luckily I was able to send my LA, could literally walk out the door and go to a pharmacy and get me the medicine that I needed. So it's just something that I'm pretty sure we've all been to a pharmacy and had to get a prescription. So the way that this bill is tackling it is right now, pharmacies, we have this middleman, pharmacy benefit managers. There's, I want to say maybe 5. I'm sorry, I don't know that exact number, about 5 in the state that they're privately or health plan owned. This bill hopes to create one PBM that is state managed for Medicaid patients. And the outcome of that is that it will help ensure transparency, accountability. We believe it will lower cost. It will protect our community access, and it ultimately will improve healthcare outcomes. That is one of the problems with existing PBMs, is that they don't have to share their reimbursement rates. They don't have to share how much they are negotiating. They have confidential contracts where they don't have to tell us what they're negotiating and how much money that they are getting. And they can extract hefty administrative fees that I've passed on to consumers and to pharmacists. So that's my ask. I feel like I have a wonderful lobbyist working for me on this because he has positioned all of the pharmacists to sit in the video with me. And I imagine that we have some pretty compelling testimony to hear on it.
Thank you so much, Delegate Carlson. I spoke with some of the folks in the audience, and I heard that many of them were also here yesterday, but when they heard this bill was up, got very excited and came back. So, all right, are there any questions about House Bill 2610 from our committee members? Okay, I don't see any. Are there folks in the room here to speak in support of this bill? If you can come forward. Great, thank you so much. Hi.
Hi, how are you? Thank you, Madam Chair and committee members. I am Dr. Anna Peoples, owner of Peoples Pharmacy, located in a medically underserved community in Norfolk, Virginia. We are the only source of health care for many in our community. At our pharmacy, we offer prescriptive, clinical, and telehealth services for our patients. This should not be about money. This should be about saving lives. So you think, well, what is the value of a life? Access to health care is something that everyone needs and deserves. However, as mentioned, the practices of the PBMs are putting pharmacies out of business every day. If all 375 community pharmacies across Virginia, both urban and rural, are forced to close, our communities, your communities, will suffer greatly. I pray that you pass this bill. Thank you for your time.
Thank you so much. Good afternoon.
Good afternoon, Madam Chair, members of the committee. Thank you for allowing us to speak today. My name is Omar Shohaiber. I operate and own a community pharmacy in Fairfax, Virginia. Pharmacy deserts are real. They're not a myth. They're all over the state. They're not just in the 5 counties and the 15 counties that were referenced today. They are in Fairfax, Virginia. They're in Loudoun County, Virginia. Anytime you go to a pharmacy and you see a long line, every time you go to a pharmacy and that pharmacy is filling hundreds of prescriptions a day, is because there are pharmacy deserts. Every time you are looking for a prescriptions and you're calling around, to find your medicine, that's because of the policies of the PBMs that are causing all of this havoc. So I hope you support the bill. We ask you for your support. Year after year, my pharmacy operates at a loss. It shouldn't be that way. If I don't exist, many of my patients will suffer. Last year, we filled 15,000 Medicaid prescriptions. This is critical for us. Thank you.
Thank you so much for coming. Good afternoon. Oh, you can also move the line forward, too, so you don't have as far to walk when you're ready to speak.
Good afternoon,
Thank you so
everyone.
much.
Thank you for giving us the opportunity to speak. My name is Aqsa Naseem, and I'm a clinical pharmacist and immunizer at my doctor's pharmacy. I'm today not even just representing myself as a pharmacist, but also a member of a faith-based organization in Nova, Adams Center. I work as a liaison between Adams Center, their healthcare network, and our pharmacy to conduct various wellness seminars, health fairs, and vaccine clinics, and to deliver specialized care to the underserved community. I also work with the Virginia Health Department to help them with immunization needs of our patients who are disabled and challenged mobility-wise. We call it at homebound patient service. A big percentage of my patients are residents of nursing homes and senior living facilities, to which the pharmacy not only delivers but conducts elaborate vaccine clinics to help them administer their life-saving vaccinations. This is the vulnerable population that needs care 24/7. Without a community pharmacy, my patients would struggle, and this bill can help ensure community pharmacies like us can stay open. Thank you.
Thank you for being here. Good afternoon.
Good afternoon. My name is Lucy Yu. I am a nurse practitioner. I've been working at my doctor's pharmacy for 4 years. I primarily do vaccines. So we do pediatric vaccine, travel vaccine. We go to home visit for bedbound patients. We go to nursing facilities. And I had parents travel 30, 40 minutes, sometimes even over an hour, so their kids can be vaccinated because we were the only facility can vaccinate kids at a time for COVID vaccine. So this is just one of the things we do for the community. We are not just business, we are a trusted partner of the community. So I'm here to ask you to vote for the bill so we can continue to care for our community. Thank you.
Thank you for being here. Good afternoon.
Good afternoon, Madam Chair and members of the committee. My name is Saad Shafi, and I'm here with the students at VCU School of Pharmacy. We are here to show our support for a single pharmacy benefit manager for Medicaid. This isn't just about transparency, it's about the future of pharmacy in Virginia. Without action, pharmacies will close, patients will suffer, and young pharmacists like us will face an uncertain future. I urge you to support this measure. Let's protect pharmacy care in the communities that we serve. Thank you.
Thank you so much. Good afternoon.
Afternoon, Madam Chair and members of the committee. My name is Laura Thompson, and I'm the Managing Network Facilitator for CPS in Virginia. I represent over 60 independently owned pharmacies in the Commonwealth. As Delegate Carlson said, this bill is very much needed for transparency of data. an adequate and fair reimbursement for our pharmacies. We know this model is successful. We've seen it in other states such as Kentucky, where we have owners that own pharmacies in Kentucky and own pharmacies in Virginia. The Kentucky pharmacies are flourishing and our Virginia pharmacies are on the verge of closure. Due to these low-cost reimbursements, we have lost and are continuing to lose many numbers of pharmacies, creating these pharmacy deserts. The latest Board of Pharmacy data actually shows that there were 28 chains and 22 independently owned pharmacies closed just last year alone. If not passed, countless stores will continue to close and thousands of our most vulnerable population will lose access to life-saving medications, life-saving vaccinations, and tests for hepatitis C and HIV by our pharmacies. Please support this bill.
Thank you for being here. Good afternoon.
Good afternoon, Madam Chair, members of the Subcommittee. Tyler Craddock, representing the Virginia Society of Health System Pharmacists. We support the bill.
Thank you. Are there any folks in the room to speak in opposition to this bill? Good afternoon, Mr. Gray.
Madam Chair and members of the committee, I'm Doug Gray on behalf of the Virginia Association of Health Plans. We represent the 5 MCOs that help manage pharmacy benefits along with the chief manager of pharmacy benefits, which is Medicaid. We respectfully suggest there are better ways to target and assist community pharmacists if you're trying to help folks, particularly in places where there are few providers. The market is very, very competitive, and one single approach doesn't make a lot of sense. Benita Anthony had a bill that really targeted trying to specifically help community pharmacists versus others, which I think you sent to the Joint Commission on Healthcare. We have several concerns with this approach. One is that spread pricing went away 6 years ago, so there isn't any savings from that. The other is that we have one single administrator of the benefit now. That's DMAS, and they have a single common core formulary. They choose the drugs. They choose the drugs based on the best rebate for the state. The state gets all of the rebate revenue. It's $690 million. So the DMAS has already achieved the savings of a single administrator. That's one of the problems with this bill. If you were to increase the dispensing fee to the fee-for-service rate, it would cost about $150 million, and 82% of the money would go to chain pharmacies. That's not exactly targeting and assisting community pharmacists. So we respectfully suggest that a deeper dive on this approach needs to be done, and we look forward to the Appropriations Committee doing that.
Thank you so much. Good afternoon.
Madam Chair, members of the subcommittee, Jeff Palmer on behalf of AHIP would agree with the comments of the Virginia Association of Health Plans, and we've done some analysis similar to Mr. Gray that the bulk of the benefits here would go to the large chain pharmacies, and only about, as he said, about 17 to 20% would go to the community pharmacies. So we're spending a lot of money to help a group that's not going to benefit as much as you might expect. So thank you very much.
Thank you. I have some questions next. Some members in the queue. Do you have questions? Mr. Delegate Orrock, would you like to ask your question now? Or
yeah, now
okay.
If I may, Madam Chair, because it was any one of the folks who are in opposition, if y'all want to come up for just a second or tag team or whatever. And now I'll ask Madam Chairman if any of those are coming up.
Yeah.
So Doug, I think we all acknowledge there's a problem.
Yeah.
And if this isn't it, how do we get there from here and resolve the issue? Because we know there are pharmacy deserts. We know it's all a matter of dollars at the end of the day. The pharmacy has to make enough money to keep the doors open. They've got low patient volume. There are only so many people, and we still have to provide the service. So if this isn't a part of the answer, do y'all have any options or alternatives?
Mr. Gray.
Madam Chair, members of the committee, the good thing about Benita Anthony's approach was that you would create a definition of a pharmacy desert, and then you would single-mindedly try to assist pharmacies in those areas so that you had access addressed. And it was more built around the idea of creating a subsidy that's really more focused and direct. There have been major changes in the pharmacy market, and the truth is that the online folks, the chain drugstores, the pharmacies, the big box stores are all competing heavily in every area. And so it's not a magic thing that you can address on the competitive side. And I think that's part of the challenge. In some pharmacy deserts, we have a population in the county of 6,000 people. There aren't many services there at all. And that's part of the challenge there. Another thing that's happened is trying to provide more payment to pharmacists for providing direct care services, which some of the folks who testified today were saying that they do, and that's fantastic, helping, and you all passed that legislation last year to help with immunizations and other primary care issues, which is also helping with another access issue. So I think there's a transformation that needs to take place, but right now, the way this approach is drafted, it doesn't really target the folks where there's the biggest challenge. And I think that's part of the effort that needs to be addressed.
Great, thank you. Did you want to respond to that, Delegate Carlson?
Chair Tran, if I could respond to some of the commentary. A few things in the opposition, seems like there definitely is an acknowledgement that there's a problem. So I'd like to clarify that I am not saying that this bill is going to penalize commercial pharmacies or big pharmacies. It is going to help pharmacists. And while it might be true that only 20% or whatever number was thrown out might go to independent, that's because independent makes up a smaller market share of what pharmacies provide or there. So that's why that's there. And then one of our public comment or testimony also mentioned that it's not about the money, which dinged for me that actually it's very much about the money. This is actually, there has been a state study. I know we heard from the lobbyists from the health plans, but there was a state study in 2019 that indicated that there would be a $32 million cost savings by going to a single state Medicaid PBM. Adjusted for inflation, that puts it about $39 million expected savings. And we know that this is feasible and possible because there are many states that have done exactly that and have realized a lot of savings, intense savings. So I'm happy that they were able to speak up. It doesn't hold a lot of water with me. And I will say I did work with Benita, and I think it's good that we will study, but we have a definition of pharmacy deserts. We know they exist, even they know they exist.
Thank you. Delegate Carlson. Delegate Shin, did you? Okay, you don't have any more questions. All right. I'm so sorry. What number is this? 2610. We have some folks online, I believe, for House Bill 2610. 2610. Nope, they're not here. I'm sorry, I keep transposing my numbers. Wrong bill, 2610. All right. We do have a letter requesting that this bill be referred to appropriations. So if there's any movement on it, it would need that referral as substituted. Delegate Orrock?
Yeah, Madam Chair, is there someone from the department here who could ask a question specifically? I have some concern about on line 360, where if this legislation comes out, this has to be in place by December 31st of this year. And that just candidly seems like a heavy lift for the amount of bureaucracy and administration that's going to be involved to get us from here to there.
Are you from DMAS? Yes, sir. Come on up. Yes, you are.
Thank you.
Good afternoon, Madam Chair. Members
Good afternoon.
Members of the committee, Jeff Lenardi with DMAS. We do have some concerns with the timeline of implementation, particularly since it requires a new procurement. And there's some other issues, and I'd be welcome to discuss them offline. I'm not going to stand in front of the train, but would welcome further discussions on the bill.
And Madam Chair, may I follow up to that, Jeff? Don't go away, please.
Did you have a follow-up, Delegate Orrock?
If I may, Madam Chairman. So Jeff, to that point, I'm also somewhat concerned because we've heard reference to other legislation that we're going to be referring to the Joint Commission for them to consider and look at. It sounds like we're trying to build the cars we're going down the road, but at the same time elsewhere trying to look at if this is the right way to be doing it. Does that give y'all any concern that we're going ahead with the program while Delegate Anthony's bill is saying, yeah, we're going to have Joint Commission look at this in a more comprehensive manner?
Due respect, I'd have to look at that bill in a little more detail. I'm not sure I'm the right person to comment on it in relation to this bill, but yeah, understood.
Great, thank you. Delegate Carlson, did you want to respond?
Yes, I would welcome, I'm happy and welcome amendments in terms of enactment. I will say we do have some other states that we can model. One did it in 6 weeks. Another one was able to do it in 4 months. I'm sorry, I don't know which respective states there were. I just know the timeline, and I'm welcome to putting in a timeline that works for our state. Happy to do that. And then with Benita's, I can't speak to her bill other as well. I cannot speak to it. It's late in the day. But I do know that our lobbyists and people who brought this bill, we all work together, so I imagine they're complementary in some sense.
I think so. Delegate Auroch, did you have a follow-up?
Madam Chairman, I had a proposed amendment. I haven't done many of those this year, if you notice, Madam Chairman.
Yes, sir. Let's hear it.
That'd be on line 360. If we were to change that by December 31st, 2026 or sooner, if practicable or if practicable.
Oh, I think it's on line 360. I think it all depends. All right. So maybe it depends on your version, but it's either line 360 or 361 to change to 2026 or
Correct.
sooner as practicable.
Yeah. Does that make sense?
Delegate Coulson?
Chair Tran, that makes perfect sense to me, but if I could put in the request that I would like to work with DMAS to get that number, and I'd be happy to bring it when it's in full, just so that we're aligning it with the time that they need.
Delegate Auroch, would that work for you? Where we've done in the past is move something forward, and the patron continues to work on it between here and full committee.
Well, and Madam Chair, the logic of the year that I picked was twofold. One, that with the language sooner if practicable, if they can do it sooner, great. But if not, then that also gives us next legislative session, if they need more breathing room or if they need to be shortened, it kicks it past the next legislative calendar so we can come back and address any tweaks we need next year.
Okay, so thank you for sharing your reasoning behind that timeline. It sounds like the patron would like to keep it as is and have this conversation a little bit more in depth with DMAS about what might be best moving into full committee.
Chair Tran, that is correct. Although Delegate Auroch, I definitely get the logic. I just want to talk to them real quick and make sure, but I'm happy to bring it as that if you just give me the chance to talk with them.
All right. Delegate Shin.
Madam Chair, at the appropriate time, I've got a motion.
Go ahead.
Madam Chair, I'd move to report and refer to appropriations with the caveat that it'll continue in conversation until the next full committee.
As substituted, Delegate Shin?
Substitute, yes, thank you.
All right. Is there a second to that motion? Thank you. So this bill, House Bill 2610, the motion is to report and refer the substitute to appropriations, and Delegate Coulson will consider a different timeline in her bill after conversations with DMAS for us to consider in full committee next week. Madam Clerk, can you please open the roll? Gary, did you? So on a vote of 7-1, we will see you in full committee. Thank you so much.
Thank you.
And as I said, we have to kind of be in and out. And so we're going to go at ease for a little bit because the Public Safety Committee has gone at ease as I'm their last bill for the afternoon. So we will be at ease. Thank you for your patience.
Everybody, can everybody take a seat so we're going to go ahead and move through some of these bills that shouldn't be too controversial and until Delegate Tran gets back. But you know what? I just saw her walk by a second ago. So we're finished all our work for the day. I'm sorry we finished everything. All right. Okay, thank you very much. Thanks, everybody. But the bill, we're going to hear Delegate Coiner's bill now. Which one was the number? 2282.
Thank you, Madam Chair. I do have 3 line amendments.
Thank you so much, Delegate Coiner. Can we report the line amendments?
Thank you, Madam Chair. So the line amendments, the first one reinserts stricken language. It reinserts the language stating that the Office of Children's Services shall consult with private special education service providers in developing the standard reporting template
Madam Chair,
for tuition.
point of order.
Yes.
Could staff give us the line number of the amendments, please?
My apologies, Madam Chair. So this is on line 39 of the introduced bill after by the office. So it reinserts that language stating that the Office of Children's Services shall consult with private special education service providers in developing the standard reporting template for tuition rates. The second amendment is on line 83 after services. It reinserts the language stating that the community policy and management team shall anticipate to the best of its abilities the number of the children and youth for whom such services shall be required. And the third line amendment is on line 85, and it unstrikes a period, so that's just technical. Thank you, Madam Chair.
Thank you so much. Can we move those amendments so they're properly before us?
So move.
All right, the bill as amended is now before us.
Thank you, Madam Chair. I serve on the State Executive Council as the member from the House of Delegates. I also serve on Commission on Youth, and this bill does come as a recommendation from the Commission on Youth. Senator Favola has it in the Senate. I understand it's made it through there unanimously. But the reason for this bill is because the Commission on Youth conducted a study on the use and impact of relief of custody and care and support of youth in 2024. And we brought together perspectives from judges, social services, CSA, community service boards, schools, private providers, courts service units, youth advocates, and families. And what we found is that we heard that caregivers petition for relief of custody, including grandparents raising grandchildren who become extremely difficult to handle, adoptive families, particular foreign adoptions, when they don't have the full medical or trauma history of children that they've adopted, and then as issues occur later on, ensuring that families have access to services and that they do not feel like they have to give up custody in order to receive the benefits of those services. So the purpose of the bill is to codify the current practice that a child or youth who has been determined to be a child in need of services by either a JNDR court or a family assessment and planning team, FAPT as we usually call it when we're out talking, is eligible for funding through the Children's Services Act. I also have Scott Reiner, who's here, and other members of both the Commission on Youth and State Executive Council if there are questions. Thank you, Madam Chair.
Thank you so much. Are there any questions for committee members, from committee members? All right. Those over here to speak in favor of the bill, please.
Thank you, Madam Chair, subcommittee members. My name is Scott Reiner. I'm the Executive Director at the State Office of Children's Services, and the administration supports the bill, and we thank you for your consideration.
Great, thank you. Mr. Ombudsman.
Good afternoon, Madam Chair, members of the committee. Eric Reynolds, Children's Ombudsman, and I do support this bill. And thank Delegate Coiner for carrying it.
Great, thank you. Are there any folks here to speak in opposition of this bill? I don't see anybody. I don't think we have anybody online. No. All right. So the bill is before the committee. Then a committee acts on a motion.
Madam Chair, substitute motion.
Delegate Henson.
Move to table. Is there a second?
Is there a second? Okay, so that motion did not receive a second. So the motion that's properly before us is to report this bill. Madam Clerk, can you please open the roll? All right, and the bill moves forward by a vote of 4-2. Delegate Coiner, I think you have another bill with us. So I think what we're going to do with House bills, if it's okay, I'd like to incorporate House bills 2655, 2752, and 2290 into House Bill 2754, and I'd like to give every patron an opportunity to speak about the bill. Delegate Coiner.
Thank you, Madam Chair. This bill is extremely important actually during the Medicaid boot camp that the chairman held for us over 2 days. This was a topic that was discussed at length. Our neighbors who are incarcerated, when they are about to be released, the lack of ability to quickly get them back into Medicaid and being able to have services and prescriptions and things lined up. So this is in the realm of the solutions, which would be allowing our Department of Corrections and our local and regional correctional facilities to allow them to share data with DMAS so that we can more quickly get people the services that they need in our communities. I'd be happy to answer any questions that the committee has, Madam Chair.
Great, thank you so much. Madam Clerk, a parliamentary procedure. Can I continue? I'm hearing statements from each of the patrons before we do that. Yes. Okay. Delegate Williams, right there. Would you like to speak about House Bill 2655 before we incorporate?
Thank you. I'm sorry. Pulled up the wrong thing. I'm sorry, I'm pulling up the wrong bill. Which bill is this?
I think you're here for 2655.
This is the medical records bill.
Yeah.
Sorry, I'm not able to pull it up right now.
It's okay. Just speak from the heart.
No, I don't know it well enough. Can I sit back down? Can we pass
Sure,
by for
of
just
course.
a minute?
All right. Okay, so, and then I know, I know Delegate Gardner's not here, but if she comes back, we can give her an opportunity later on. But let's vote as a block vote to incorporate 3 bills: House Bill 2290, House Bill 2655, House Bill 2752, into House Bill 2754. Madam Clerk, is that a recorded vote?
It's just a voice.
It is a voice vote. All those in favor say aye. Aye. Any opposed? All right. So House Bill 2754 is now substituted with all these in it, is now before us. Are you ready? Did you want to make your statement?
It's my understanding that my bill was incorporated into other bills, so I support the incorporation and just ask to move forward.
Great. Thank you so much. I appreciate that. Delegate Singh.
Madam Chair, I believe we've talked about this bill briefly, but I'll just say that currently for incarcerated individuals, Medicaid only pays for inpatient hospitalizing for more than 24 hours. Federal requirements and new programs allow Medicaid-eligible youth and adults to receive specific services pre-release to allow for improved access to care through their discharge. This bill ensures that the Virginia Department of Corrections, Department of Juvenile Justice, and local and regional correctional facilities share an incarcerated person's medical and mental health information with the Department of Medical Assistance Services. Representatives from DMAS are here if you have additional questions.
Great. Thank you so much. Are there any questions from our committee members? All right. Are there any folks in the audience who wish to speak in support of this bill? Where's Jeff coming up? Are there any folks who wish to speak in opposition? All right. This bill, if it moves forward, does not have to be referred to appropriations. The committee operates by motion.
Move to report.
As a substitute. Great, thank you. The motion has been moved, and the substitute has been, the motion has been properly made and seconded to move to report the substitute. Madam Clerk, can you please open the roll? Please vote. All right, this bill moves forward as substituted on a vote of 6-0. Thank you very much. I'm going to call Delegate Obenshain up. Good evening.
Thank you, Madam Chair, members of the committee. HB 2344 directs the Department of Behavioral Health and Developmental Services to take steps necessary to implement an extension of Part C of the Individuals with Disabilities Act to allow children 4 years of age or younger to receive early intervention services. Currently, IDEA covers intervention services for children until they reach age 3. Last year, the Department of Behavioral Health and Developmental Services served over 23,000 children and their families in early intervention. This bill would expand those services up until the age of 5, and this would ensure that kids with disabilities receive consistent services until they're school-aged. Early intervention services are designed to meet the developmental needs of infants and toddlers with disabilities, either in physical, communication, adaptive, or social or emotional development. Expanding this program would provide services to more children earlier in their life, helping with assistive technology, with audiology services, family training, counseling, home visits, mental health services, nutrition, occupational and physical therapy, special instruction, speech language, pathology, transportation, and vision services. It will prevent children who are already receiving services from losing those services before they transition to school. With the current cutoff age at age 3, many children have a gap in services, and it sets them back and ends up really, in many cases, requiring the Commonwealth to provide services for longer after they reach school age. This bill would also help relieve some of the demands on our school special service providers. Reaching our children with these vital services in the early years in a critical period of development provides them with the support and the tools that they need for success in school and later in life. It importantly also, I believe, will save the Commonwealth money down the road by reducing the need for more costly interventions later on. This should not be a partisan issue. Other states have requested and received the same extension of these services, including Tennessee, and this effort is an investment in our young people. And I would ask the committee to support this bill. Thank you very much, Madam Chair.
Thank you, and thank you for your patience this evening. Are there any questions from committee members? All right. Are there any folks in the room who...
Madam Chair.
Oh, sorry. Delegate Henson.
To confirm, there's a FIS on this, correct?
Yes, there is. Yes.
Thank you. Are there folks in the room who'd like to speak in support of the bill? No. Oh, hello. Good evening.
Good evening, Madam Chair, members of the committee. You don't often hear me speak on this, but as president of the Virginia Society of Human Life, my name is Olivia Turner, and the truth is that our organization is committed to providing assistance and support for the health and well-being of individuals with disabilities, those who are aging, et cetera, along with mothers and their babies. So this is a bill that we think makes sense because our children from infancy through to school age need to be ensured that they will be receiving the appropriate levels of health care and other services that our Commonwealth can and does provide to other children. So we applaud the delegate for bringing this forward.
Thank you so much. Are there other folks who'd like to speak in support? Are there any folks in the room who'd like to speak in opposition to this bill? All right. Online, I believe Ms. Woodard. Thank you so much for waiting with us.
Hi, can you hear me?
We can. Are you able to turn on your video?
Oh, yes, I'm sorry.
Yay. Thank you so much.
How's that? Yay. So my name is Dodie Woodard. I am a speech language pathologist and I own a small business in Pulaski, Virginia. And we provide PTOT and speech, physical, occupational, and speech therapy for children in the birth to 3 area. And at any given time, we cover 9 counties and 4 cities. So we're pretty widespread. We really love what we do. The coaching model for early intervention empowers parents to be a therapist every day. And when they age out at the age of 3 and they move on to outpatient or school services, a lot of times those services aren't available in our regions. And as you know, we have a really, really massive need in our regions for early intervention services due to the opioid crisis. So I very much support this bill and thanks Delegate Obenshain for bringing it forward because we desperately need this extension in our regions in Virginia.
Great. Thank you so much. And thanks for waiting and for sharing your testimony. All right. Delegate Sickles?
Yeah, I just want to speak to the bill. Part C has been around for a long time. It's one of the first things I learned about when I got elected 20 years ago. And it's a great program. It's had good reviews the entire time I've been here, and I'm glad we can try to expand it. We have $8 billion worth of requests from our fellow members, and so we're gonna have to sort through that upstairs. But it'd be great if we could do this. I mean, it's not like we haven't tried before. We could have done this any year that I've been here, and we haven't done it. So maybe this is the year. Maybe you're the lucky guy that gets this through. But you know, we've been too conservative to do this prior to now. But anyway, at proper time, I'd like to make a motion to report the bill and refer to appropriations.
There's a motion to report and refer to appropriations.
Second.
That's been properly seconded. HB 2344 is before us. Madam Clerk, can you please open the roll? All right, this bill moves forward to be referred to appropriations, recommended to be referred to appropriations by a vote of 6-1. Thank you so much, Delegate Obenshain.
Thank you, Madam Chair.
All right, I'm going to ask Delegate LaVere Bowling to come up. Good evening.
Good evening. It is evening now. Yeah. Okay. Madam Chair, do you have a pleasure on which bill we take up first? Or?
Whichever you'd like.
Okay. Let's go ahead and do HB 1927. We'll just go in numerical order.
All right. HB 1927 is before us. And if this bill moves forward, committee, it needs to be referred to appropriations.
Yes. Thank you, Madam Chair and subcommittee members. HB 1927 seeks to improve access to critical healthcare services for pregnant and postpartum individuals across our Commonwealth. This bill addresses an essential gap in our healthcare system by expanding the coverage of remote patient monitoring services provided through telemedicine to include all pregnant and postpartum patients, not just those with high-risk pregnancies, as is the case under current law. This change will allow a broader group of individuals to benefit from telemedicine and remote monitoring services, which we all can agree will play a crucial role in preventing complications and improving maternal health outcomes, while also helping to close the disparity gaps in rural areas and in healthcare deserts where pregnant individuals are driving an hour or even more, or even in some cases, parts of our state, they're going to another state to be seen by OBGYNs and other necessary healthcare providers. So this expansion will also assist in supporting working families as well. We know that many Virginians struggle to make ends meet, and when pregnant, having to take a whole day off of work just to attend one doctor's appointment in person, it can be the difference between a paycheck that covers all your bills and one that doesn't. So HB 1927, again, is an important step in improving maternal health care in the Commonwealth. And I ask that the committee please support this legislation to join me in improving our maternal health care. Thank you.
Thank you so much. Are there any questions from our committee members? Okay, I don't see any. Are there folks in the room who'd like to stand up in support of House Bill 1927? Good evening. Oh, it's a whole line.
Good evening, Madam Chair, members of the committee. My name is Davis Gammon. I'm with the Virginia Hospital and Healthcare Association. We strongly support the legislation, and we'd like to thank Delegate Bowling for bringing it. We saw over the summer, as we kind of worked through the Speaker Select Committee on Rural Health, we saw the prevalence of really two challenges in rural communities: maternal health and telehealth. This bill kind of marries those two challenges together and really does address them in a really effective way. So we really do hope, by expanding this not just to high-risk patients, which are very difficult to identify if you don't have access to those preventative services, to remote patient monitoring. So really think that this is going to more effectively serve our most vulnerable Virginians, particularly those on Medicaid. So we hope that you will advance the bill forward to the full committee, and I thank you for your time.
Thank you so much. Good evening.
Hi, Chair and subcommittee members. Evan Hoffman with Philips. We are a healthcare technology company, also a very large provider of remote patient monitoring services for pregnancy, both prenatal and postpartum. And so this is an amazing opportunity to expand these services. Just a couple weeks ago, we had someone in our program who had high blood pressure. She was on an RPM monitoring program. Her blood pressure went into severe zone where she was at risk of having a stroke. The remote monitoring picked it up, and we were able to get her to the hospital and save her life and her baby's life, and everyone's healthy. So this actually affects lives, so we support this bill. Thank you.
Thank you so much. Good evening again.
Good evening again. This is a great committee because there's a lot of good things happening. I want to support the delegate very strongly, Virginia Society of Human Life, in our partnership with many of the mother helping programs around the state, are very much aware that particularly those programs that exist in the rural parts of the state or in even sometimes urban areas in the state do recognize that there is a lack of opportunity for some women that they serve to get access to care or to be able to get to care. Sometimes they can't get to them, they can't get anywhere else. So this is a great advantage that we need to move forward. It is a modern age. Again, we're on a moment in time when we need to take advantage of what we can do. Thank you, Delegate, and I encourage the committee to support this kind of forward thinking.
Thank you. And good evening.
Good evening. Amy Perrin-Sabin on behalf of Baby Scripts. We are also a mobile provider of remote patient monitoring. We do it now with high-risk pregnancies in Virginia. We look forward to the opportunity to do it for both pregnancy and postpartum. And like the gentleman who testified before, we do see really good real-life examples of when you're able to track that blood pressure from afar and what a huge difference it makes in people. So we appreciate this. We also support 1929, so I won't come up here again to save you guys some time. Thank you.
Thank you.
Jeff Palmer on behalf of Anthem, and we support the bill. Thank you.
Great. Thank you so much. Are there any folks here to speak in opposition to House Bill 1927? All right. Committee operates by motion.
Move to report and refer to appropriations.
Second.
There's been a motion that's properly seconded to report and refer to appropriations, House Bill 1927. Madam Clerk, if you can please open up the roll. All right, and this bill moves forward by a vote of 7-0. Delegate Livia Bowling, your next bill.
Thank you.
1929.
Yes, 1929. HB 1929 is a bill that seeks to, again, address an important gap in healthcare accessibility and support for pregnant, prenatal, and postpartum individuals in the Commonwealth who are eligible for Medicaid. The bill is to direct the Department of Health to contract with a mobile app developer to create a comprehensive, user-friendly app that will assist these individuals in managing their health and accessing, most importantly, critical state resources. The mobile app will serve as a tool to provide ongoing health support, education, reminders, and access to resources throughout pregnancy and the postpartum period. The bill does stipulate, if you are tired and haven't read through the whole thing, that within 180 days of the bill's effective date, the Department of Health must submit an RFP to develop this app, and the RFP will include clear deliverables that include design, development, implementation of the app to ensure that it meets the needs for all of our wonderful Virginians. This is really a significant step forward in using technology because as we all have been on our phones all day, we know it is the #1 way in which we receive information and communicate. And so having an app such as this to be able to connect state resources with some vulnerable populations, such as pregnant women across the Commonwealth and postpartum individuals, is very important. So again, by providing mobile application that offers continuous real-time resources, we can enhance healthcare outcomes, reduce disparities, and give every individual the opportunity to receive the care and support that they deserve during one of the most critical times of their lives. And with that, I will pause and ask that you all please support this bill.
Thank you so much, Delegate. Are there any questions from our committee members? Are there folks in the room to speak in support of this bill? All right. Good evening.
Hello again, Evan Hoffman from Philips Healthcare Technology Company. We're also a developer of Pregnancy App. We own Pregnancy Plus. In fact, 52,000 families in Virginia used our app last year, or 55% of total pregnancies. And what we find is that there's often a disconnect. There's amazing programs that exist at the state level and in their community, whether that's home visiting, whether that's doula services, WIC benefits, mental health services. But the challenge is often awareness. Many individuals don't realize that they're eligible for these programs or that these programs even exist, but they're using their phone every single day to learn about their pregnancy. So can the phone and the Pregnancy App be a platform to drive awareness and utilization of those programs in their community and at the state level? Michigan did this 2 years ago. We won an RFP and we've been partnering with Michigan since that time. We've helped connect 32,000 Michiganders who are on Medicaid to state government programs, including 3,000 into home visiting. So this apps can really help drive participation into important state programs that actually are evidence-based and help improve outcomes. So thank you.
Thank you so much. Good evening again.
Once again, thank you, Delegate. I am a boomer, but I absolutely love the fact that we're in a moment in time when we're moving forward. I know, again, from the we have close to 52 mother helping programs scattered throughout the Commonwealth on all regions of the Commonwealth, but our friends around the state are recognizing more and more that their younger patients and clients need to have access to online resources because that is how they find where they need to go and what's available. And even those individuals running the programs will benefit by these apps because they'll be able to track a little bit more information for their clients. So it's a positive step. And again, this is the way we need to go.
Thank you so much. Are there any folks in the room who would like to speak in opposition to this bill? All right. This bill, if you move forward with it, needs to be reported and would need to be referred to appropriations.
Move to report and refer to appropriations.
Second.
We have a motion that's been properly seconded to report and refer House Bill 1929 to appropriations. Madam Clerk, if you can open the roll. Okay. And it'll move forward by a vote of 7-0. Thank you so much, Delegate.
Thank you.
Delegate Carr, are you still there?
Thank you so much, Madam Chairman. I have HB 2160 about designated staff support. HB 2160 allows Medicaid to recognize and pay for direct support staff to assist individuals while they are in the hospital. The hospital can be confusing and a bit terrifying if you do not understand what is happening or why it is happening. Communication is an issue, following directions is an issue, cooperating with treatment or directions can be an issue. A familiar face, staff who work with the individual regularly and has the skill needed to support the individual is trusted and much more effective, and we know that aids in recovery. The 2022 CARES Act allowed Medicaid to have this option. It's time we did so in Virginia. This bill specifies the limitations, and there is a budget amendment to go with it. I hope the subcommittee will consider the legislation favorably, and there's someone here to testify on behalf, Jennifer Fedor.
Thank you so much, Delegate Carr. Are there any questions from committee members? All right. Are there folks here? I see a couple of folks, Jennifer, and some others waiting to speak in support of the bill.
Thank you so much, Madam Chair. Some of you remember that we have attempted this a couple of years with budget amendments only and decided this year it was time to bring it as a Section 1 bill so we could actually discuss it a little bit and answer any of your questions that you have. We've also rather significantly constrained the scope this year to bring it into something we hope, out of all the requests that the House Appropriations Committee gets and Senate Finance gets, it will slide in there and fit. It's not terribly expensive. So I want to first say quickly that we're in no way faulting the hospitals. They do their job. But these are very unique situations and unique individuals. And as someone pointed out to me the other day, it's not always that they know the patient, but sometimes it's that the patient knows them and trusts them. And so that eases the way. So thank you. I hope you consider it.
Thank you so much. Good evening.
Hi, good evening, Madam Chairman, members of the committee. Jennifer Faison here on behalf of the Community Services Boards in Virginia. We support this bill.
Thank you. Good evening.
Good evening, Madam Chair, members of the committee. Randy Pearson with Two Capitals Consulting on behalf of the Autism Society of Central Virginia as well as Tidewater, Virginia. We strongly support the bill and thank Delegate Carr for filing it. Thank you.
Thank you. Are there any folks in the room who wish to speak in opposition to the bill? All right. We have some folks online. I'm going to call Terry Morgan.
Hello, this is Terry Morgan with the Virginia Board for People with Disabilities. We thank Delegate Carr for carrying this bill. We think it's an important bill for the reasons that have been mentioned, and it's going to have a real positive impact on people with disabilities who are in really difficult circumstances in their families, to have somebody who they know and who they trust when they're in a hospital setting. Thank you.
Thank you. And Teresa Champion.
Thank you, Madam Chair, members of the committee. I want to thank the patron, Delegate Carr, for this bill. This is so important for many families. I'm Teresa Champion with the Virginia Autism Project, and we support this bill. Many of our families have experienced their loved one being in the hospital, needing extensive support, and hospital staff that cannot provide, and nor should they. Individuals need very familiar, specialized support to help them. Please vote in support of this bill. Thank you.
Thank you so much. This is an issue I've heard a lot about from my own constituents, Teresa being one of them. All right. It's back with the committee. And as I said, if it moves forward, it needs to be referred to appropriations.
Move to report and refer to appropriations.
Second.
Okay, there's been a motion properly seconded to report and refer House Bill 2160 to appropriations. Madam Clerk, if you can open the roll. And this bill moves forward on a vote of 7-0. Thank you so much for your patience, Delegate Carr.
Thank you, Madam Chair, members of the committee.
Yes, Delegate Batten.
Thank you, Madam Chair, members of the committee. I have before you today two bills. If it be your will, I will go ahead and start with House Bill 2339 relating to foster care documents.
Great, thank you. House Bill 2339 is before us.
House Bill 2339 requires the Virginia Department of Social Services to ensure that a child in foster care obtains a state-issued photo ID either at the child's 16th birthday or within 6 months of that birthday. The reason for this bill is because foster families are unable to procure these themselves because they are not the custodian of documents such as a birth certificate. We're really looking to have a state-issued photo ID, and it needs to be accessible to the child or the child's foster family. The problem is that without this photo ID, the child's unable to get a job or open a bank account, which are some of the beginning steps to transitioning out of foster care and back and into adulthood when they reach 18. There's been the thought before that student ID might be sufficient for some of this, but you cannot use a student ID to open a bank account or to get a job. So again, without a state-issued photo ID, a child cannot attain the hallmarks of stability that would allow them to succeed as an adult as they migrate out of foster care. And I did have a lady here who was planning to testify, but she had to catch a flight at 6 o'clock. And so after taking any questions, I'd be happy to read the testimony that she planned to present.
All right, first let's see if there are any questions from our committee members. Okay. Would you like to read her testimony?
Yes, thank you, Madam Chair. The individual's name is Lexi Finlayson. She's a lawyer, and she and her husband are foster parents. Their foster daughter was placed with them when she was 2 years ago, at the age of 16 years. When she was placed with them, she had no identification documents, either in hand or in her file at DSS. Despite the fact that she had been in foster care since 11 years old, she did not have a birth certificate, social security card, a learner's permit, driver's license, or even a health insurance card. During the first 3 months that they were fostering her, they paid for her medications out of pocket for this reason. As they prepared for her for adulthood, this became a problem because they could not help her get a job without these documents, open a bank account without these documents, fly by plane with her, or even have her sit for certain educational tests at certain locations. Under the current status, the child is provided these documents on their 18th birthday. This is also the day that they may lose support from their home or case manager. Without these documents previously held before the age of 18, they do not have a chance to get a job or set up a bank account, leaving them immediately vulnerable to homelessness, trafficking, and criminal activity. This is a simple solution that would move the clock up a little bit to allow them to obtain those documents at the age of 16 so that they would be more ready to transition out of foster care at the age of 18. I'm happy to answer any questions from the committee.
Great, thank you so much. Oh, are you here to speak in support, Valerie? All right, there's another person to speak in support. Good evening.
Thank you, Madam Chair. Valerie LaRue from Virginia Poverty Law Center. I'm also speaking on behalf of Voices for Virginia's Children and the Virginia Foster Care Policy Network. We do support this bill. I think most foster care agencies do work with the youth to get them the documents they need when they need it, but we do have a patchwork of 120 different departments, and they all handle things differently, and so this will make it more uniform. So thank you. We support it.
Great, thank you. Good evening, Mr. Ombudsman.
Good evening, Madam Chair, members of the committee. I support this bill. Thank you.
Thank you so much. Are there any folks who are here to wish to speak in opposition to this bill? All right, the committee operates by motion.
Madam Chair, I do have a question before the motion.
Delegate Henson, I apologize.
This may be a question for Department of Social Services. I see you over there.
Good evening. Spotted in the crowd.
Hello, Mr. Carl. I do believe the intent of this bill, but just to confirm, because I am in a foster family and we've had fosters, Department of Social Services do work with foster families to provide these documents in order to give these children what they need. So for an example, I had a foster brother who wanted to get his permit to drive a car. My mom contacted Social Services. The social worker gave her the document. They went together to DMV to give them the documents that they needed in order to provide that. Just want to confirm that is something that Department of Social Services currently works with when it comes to foster.
Yes, Madam Chair and Delegate Henson, that's correct. The standard process for how this works is when a youth comes into care, if they do not have those documents, we get those documents, obtain those documents, and hold on to them on behalf of the child. And then how the statute currently works is when that youth is aging out and leaving care, we make sure they leave with that packet of documents that goes with them. To Delegate Batten's situation that she was sharing, I was just shaking my head because that is not, it should not be occurring. It is not consistent with how we already practice, but as you heard Ms. LaRue testify, we have 120 local departments and sometimes the practice is not followed, but this should not be occurring. And what she's recommending is that we just provide that to them at 16. And so current process, how that goes. So I hate to hear these situations when they occur, but to your question, the agency should already have it. They should be providing this to the foster parent when they transition. We hear from foster parents where this breaks down with the foster parent, but foster parents shouldn't be paying for medications out of pocket and all those different things that came up in these situations. It's, as I tell people, this is bad practice. And it should not be occurring from that end of it, but we have these situations that occur.
Thank you, Mr. Henson. Delegate Henson. Are there any other questions, committee members? All right. We operate by motion.
Move to recommend reporting.
Substitute motion, Madam Chair.
Delegate Henson.
Motion to table.
Second.
Okay, there's been a substitute motion to table this bill that's been properly seconded. Madam Clerk, can you please open the roll? All right. The bill has been tabled on a vote of 4-2. Delegate Batten, you have 2340.
Yes, thank you, Madam Chair. I have before you House Bill 2340, also relating to foster care reciprocity. Currently, there are 120 Department of Social Services offices in the Commonwealth of Virginia, and each of them have unique training requirements. This bill requires reciprocity for certification between DSS offices and licensed child placing agencies. Just a side note, many DSS agencies contract with another outside agency to help them place children, and many families are also certified through that agency as opposed to DSS. But currently, if a family is certified in one county, the certification is not recognized in other localities. We've heard a lot of media reports over the past couple of years about children not being able to find foster homes and sleeping in the DSS offices and facilities. This is not necessarily due to lack of concerned foster parents. The challenge that we have is that prospective foster parents who might already be a foster parent in one locality cannot necessarily travel for hours across the Commonwealth to obtain the training that they need in order to be certified to foster that child, and is certainly unable to do that in a timely manner. This bill would increase, ultimately, if adopted, the number of available foster homes throughout Virginia by ensuring reciprocity. And again, as I mentioned, there was an individual here who had planned to speak to the bill but had to step out, and I'm happy to read her comments.
Great. Are there any questions from the committee? All right. Are there any folks, would you like to read the testimony first? Go ahead.
Certainly. Under the current status, if a family is fully licensed to foster in one jurisdiction and is even taken in foster children successfully, they cannot foster in another jurisdiction, but instead must be trained all over again. An example was when this family tried to set up respite care with a friend in our foster support group who was fully licensed in 8 counties. She was not licensed in the specific county where their foster child was from. She was told that even though they had 0 respite homes available and no plan or options for respite, she had to do over 40 hours of training before our foster child could spend a weekend of respite care with her. It's been indicated that there are about 163 children in Virginia who spent at least one night in hotels, ERs, or government offices due to shortage of foster homes or other permanent housing. I understand that as a Commonwealth, we certainly enjoy our independence at a local government level, and reciprocity would allow DSS offices to maintain their independence while foster families choose their license through based on distance and circumstances, while expanding the foster home map and helping children to have access to stable, safe homes.
Thank you for sharing her testimony. Are there folks in the room who'd like to speak in support of House Bill 2340? Okay. Are there any folks who'd like to speak in opposition? All right, it's back with the committee. This bill does not need to be referred to appropriations. Chairman Sickles.
Would Mr. Ayers return to think so? Mr. Ayers is our resident expert in all foster care and adoption issues in the Commonwealth. And can you tell us, would this be helpful to you?
Madam Chair and Sir Uber Chair, I guess I'll, from that end of it. So the reciprocity issue has come up, and it's been a longstanding issue for a number of years, and primarily because we are a locally administered system. And so as localities do the individual approvals, we don't do state-level approvals. Each individual locality does the approvals of the foster homes. And so if you're approved in, let's just say Richmond City, you're approved in Richmond City. If you move to Chesterfield, you may have to get reapproved in Chesterfield. So we hear from foster parents that that's a concern to them. And then, if you're through the 3-year approval process, having to go back through the entire training to get recertified in another locality just because you moved a couple of miles from that end of it is an issue for the foster parents. And so Senator Wampler, not his dad, Delegate Wampler. Sorry, I was thinking back to his dad. So Delegate Wampler had a bill a couple of years ago to have agencies share their home studies. So that was a step in this direction. So I don't know how much difference this would be from the process that Delegate Wampler included in legislation that passed this body a couple of years ago. So that's current process, but we do get complaints from foster parents whenever they move about having to do the training and what doesn't transfer from one jurisdiction to another.
Mr. Chairman.
Yeah. So you're saying that the current practice now is to, if the foster parents move to another jurisdiction, that they share the home study or whatever they had before with the new jurisdiction. That's the current process, and we're trying to eliminate that, so they don't have to share the home study or whatever that they did in Richmond City with the Chesterfield.
Madam Chair and Mr. Chairman, we would not be looking to eliminate anything that makes it easier for a foster parent to continue fostering irregardless of where they live from that end of it. So what we've been working on as a Commonwealth for a number of years is easing the process for foster parents to be approved and then easing their approval to continue fostering as irregardless of which locality that they moved into. So that's what the body has done over the years. As you look at this specific legislation, it also applies to licensed child placement agencies, and I'd ask the delegate about the licensed child placement agencies because traditionally they have a different model than what we have as the local departments, and if they had any feedback, and they aren't here to testify, so obviously they didn't bring any concerns forward with that conversation, but that was the other piece that has come up in this between the local departments, which is part of my piece of it, and then the licensed child placement agency. I'm not sure that helps you a whole lot with what you're trying to answer for a very complicated process depending on which entity is getting approved.
Mr. Chairman, do you have follow-up?
No.
You're good?
Thanks.
Okay.
Thanks,
Delegate Orrock?
Yeah, Madam Chair. Are there problems we need to try and address, and whether this is the answer or not?
So, Madam Chair and Delegate Orrick, yes, there are issues that we need to address. We support what's in front of you from that end of it as a step in improving that process from that end of it. So we feel like this is a positive step in that situation, which I believe is what Delegate Sickles was getting to as well, is that we support that, and that's where we feel like we should move in that direction.
Thank you.
Thank you so much. Our committee operates by motion.
Madam Chair, substitute motion.
Delegate Henson.
Motion to table.
Second.
There's been a substitute motion to table this bill that's properly seconded. Madam Clerk, if you can open the roll. That motion passes by a vote of 5-2. Thank you so much, Delegate Batten.
Thank you, Madam Chair, members of the committee.
Thank you. Delegate Sewell.
Thank you, Madam Chair and members of the subcommittee. I present House Bill 2534, and I have an amendment in the nature of a substitute.
Great. Would you like counsel to report that, or would you?
Yes, please.
All right, counsel.
Madam Chair, the substitute removes reference to the specific regulation, pardon me, that has the prohibition on crisis stabilization services at institutions for mental disease, as they're referred to in the regulation. It instead just states that that DMAS will seek the necessary federal approvals to remove the prohibition against the use of crisis stabilization services in those circumstances. On receiving that approval, it also says that DMAS will have the authority to implement that change through agency guidance documents prior to the completion of any regulatory review process, and they shall promulgate such regulations within 280 days of receiving federal approval.
Thank you so much. Can we move the substitute so it's properly before us?
Move the substitute.
Second.
All right, all those in favor say aye. Aye. Any opposed? Okay, the substitute is properly before us. Delegate Sewell, House Bill 2534.
Thank you, Madam Chair. The Prince William County Crisis Receiving Center is a key component to the behavioral health crisis system in Northern Virginia. And as we seek to expand our reach in recent years, the locality as well as the Commonwealth of Virginia have made significant investments towards this much needed facility, which is located in Prince William. Earlier this year, the facility was designated as an institution of mental disease, which prevents full reimbursement from Medicaid without the appropriate waiver and authorization. As a result, DMAS has filed an 1115 demonstration waiver amendment with CMS, and this waiver, if approved, would give the Secretary of Health and Human Services the ability to approve experimental pilot and demonstration projects similar to the Crisis Receiving Center in Prince William County. And we recognize that this is essential. So with approval, which we're just going to claim, it will allow Medicaid billing with the federal match for all crisis services that will be provided at the Crisis Receiving Center and future centers, which will come online as part of the Right Help Right Now initiative. This legislation supports the waiver in it, and it directs DMAS to remove the regulations that prevent 23-hour observation units and crisis stabilization beds from being supported in facilities deemed as IMDs, as I just noted. And again, referencing the Prince William County Crisis Receiving Center, which is scheduled to come online at the end of this year, which we're very excited about. It will provide 16 beds for adults, 16 beds for youth. And it will also offer both walk-in behavioral health urgent care, regardless of ability to pay, as well as it will enable rapid admissions for police drop-offs. And this key partnership, again, is an opportunity for us to work together in providing critical crisis services in our community.
Great. Thank you so much, Delegate Sewell. Are there any questions from our committee? Okay. Are there folks in the audience who'd like to speak in support of this bill?
Thank you, Madam Chair. My name is Jennifer Fedora. I represent Connections Health Solutions. I'm here to answer questions, but the delegate did an excellent job of explaining it. This tidies up the regulations, the state plan, just so that it all comes together nicely when the waiver is approved. So we are very much in support of this bill.
Thank you so much, Jennifer. Good evening.
Good evening again, Jennifer Faison with the Virginia Association of Community Services Boards. We also support this legislation. Thank you.
Thank you so much, Jennifer. Are there any folks in the audience who wish to speak in opposition to this bill? Okay. I think we have somebody online, Lisa Madron. Thank you so much for your patience. Good evening.
Good evening, Madam Chair, members of the committee. Thank you so much. I am Lisa Madron, and I am representing Prince William County Community Services. I'd like to thank Delegate Sewell for bringing this very important bill forward, and we strongly support this as it really, as was said, will allow crisis stabilization services to be in a designated IMD. So we ask for you to support it. Thank you.
Great. Thank you so much. Okay, one moment. The bill is now back with our committee, and I do not see that needs to go to appropriations, Mr. Chairman.
Oh, Madam Chair, that's just what I was about to ask, if it had a FIS on it. I don't see one in the system, so if there is none, I would move to report.
Second.
All right, there's been a motion to report and refer, I'm sorry, just report this bill, House Bill 2534, as substituted. All right, as substituted. Madam Clerk, can you please open the roll? And your bill moves forward on a vote of 7-0. Thank you so much, Delegate Sewell.
Thank you, Madam Chair and members of the subcommittee.
Delegate Glass.
Good evening. Am I on? Is this on?
Good evening, Delegate Glass.
Just making sure. Before you, I have House Bill 2457. This bill begs the question if it's acceptable for the state to take federal benefits from children in foster care. In most states, foster care is free to children. However, in some, the only children that are being impacted are children that have disabilities or their parents, one or both of their parents have passed away. So this legislation is meant to ensure that foster children, specifically military survivor benefits, are retained full access to those funds for the future needs that they may have at the end of their offset, and are not spent by the Commonwealth to offset any of the expenses that occurred for the Department of Criminal. I did a criminal justice service this morning for the Department of Social Services. So what it does is it does 4 particular things. Number one, it already says that local departments for social service must, if they apply for those benefits, they can apply for those for the children that qualify. Number 2, that there's a protection specifically for military survivor benefits that they can't be used to cover child care expenses that the Commonwealth essentially is responsible for. And 3, the preservation of benefits. So serving as, with LDSS serving as representative pay, they must place these military survivor benefits into a trust or a protected instrument. So exempting the federal asset and from limited resources. So there's a very little impact. I think the number we got that there were 14 foster care children in 2024 that had military affiliations and were subject to these benefits. And that's the crux of the bill. We're just saying that if those children had a survivor benefit, they lost their parent who had military service, that we would put that funding that was there for them into a trust so that when they leave foster care, they are able to start on 2 feet.
Thank you so much. Are there any questions from our committee members? Okay. Are there folks in the room here to speak in support of this bill? And I feel like we've had this conversation about this issue previously, right? I see Colleen here.
Madam Chair, members of the committee, we have Colleen Miller from the Disability Law Center. We have a problem in Virginia of children leaving the foster care system, particularly children with disabilities leaving the foster care system with no supports, no resources, and we find that they are often homeless. The bill that the delegate is bringing to you today is just a tiny step towards addressing that. As she mentioned, it may address 14 kids at this point, but it's a step. It's a step that we can take without busting the budget, and I hope that the committee will take that step. Thank you.
Thank you so much. Good evening, Mr. Ombudsman.
Good evening, Madam Chair, members of the committee. Eric Reynolds, Children's Ombudsman. I support this bill for a couple of reasons. The provisions protecting the military survivor benefits, but in addition to that, it puts into regulations, the practices that local agencies should be engaging in to protect children's federal benefits. We have some guidance right now that is just guidance. And so, you've heard that we've got 120 different local agencies out there, all doing it differently. And so this would help with consistency and making sure that with it being in regulation, those good practices should be engaged in all 120 local agencies. And that's why I support the bill and hope that you do as well. Thank you very much.
Thank you very much. Are there any folks who want to speak in opposition to this bill? I don't see anyone. And it is with our committee. Delegate Henson.
Madam Chair, just to confirm, this does not have a FIS.
No, it does not need to be referred to appropriations.
Second.
All right, there's been a motion to report House Bill 2457, and it's been properly seconded. Madam Clerk, if you can please open the roll. All right, this bill will move forward on a vote of 7-0. Thank you for your patience, Delegate Glass.
Madam Chair.
All right, we have 2 bills left, and we will go with the Uber Chairman and his bill, House Bill 2394.
Thank you, Madam Chair and members of the subcommittee. This bill is to help keep, in general, big picture, to help keep people in their homes longer. It's been our policy for quite a while now to do everything we can to keep people in their home as much as possible by developing some community-based services. Right now, Virginia, obviously, our need for long-term care services is growing. And if you need, it can take Medicaid some time to process applications. Nursing homes traditionally have been able to assume some financial risk and accept applicants before they can accept them into the home before their application has been processed. But many home and community-based service providers are unable to assume the same kind of risk. So Virginians are often admitted to nursing homes while less expensive options would be available if they were taken advantage of. This bill has been brought to us by AARP Virginia, so I'll let them say a few words now, and they'd probably save us all time if they just came up right now and talked about this bill. This is a bill that is supported by the PACE movement that we have, which is the way that we really need to go as we get older, and which we are all doing.
We are all aging by the minute. All right. Are we okay if he shares information before we go to questions? Go ahead, sir.
Good evening, Madam Chair. I was going to use Scott's accent to voice PACE's support, but I don't think I can pull it off anyway. So Jared Calfee with AARP Virginia. So what this bill is trying to address is the disparity that Chair Sickles laid out between home and community-based services and nursing homes. Currently, if you apply for Medicaid to go into a nursing home, the nursing home will determine if you are likely to be approved, and if so, they will take you in immediately and presume eligibility until your full approval comes through. Home and community-based service providers cannot do that. And so what happens when someone applies for Medicaid for home and community-based services could be one of a few things. One is they have to wait to get the services that they need, and their health conditions can deteriorate and end up being more problematic later on. And two is they will go into a nursing home because they need immediate care, even though they may not need that level of immediate care and would otherwise be all right staying in their home. And so what this bill does is it gives the state a mechanism to determine if someone is likely to have their Medicaid approved, and if so, grant them a period of presumptive eligibility so that they can access home and community-based services immediately and remain in their homes being provided with those services through the period between their application and when they're actually approved for Medicaid, which can take up to 45 days or up to 90 days in some cases, which a lot of people just don't have that time to wait. And so I hope the committee will support the bill.
Thank you so much for that explanation. Are there any questions from our committee members? Delegate Orrock?
Of course. Madam Chairman, if I may. Delegate Sickles, I understand the concept. I guess my challenge as I look at this, we've got to get the waivers in order to pay for this. We've got to get the language there, the second enactment language.
I don't think waivers would be the right term.
That's probably not the right term, but the second enactment says if we don't get the necessary approval for federal financial participation, then this expires July 26. And so I'm trying to understand the fiscal implications to the state that if we go ahead with this and then the federal money doesn't come, the state will have front-loaded it and we're never going to get that federal match. Is that how this works out, or help me with that one? I've never gotten to spend any money because they don't let me on the program.
Go ahead.
Yeah, so there's two routes the state can go here. One is amending our 1915C waiver, which is kind of the standard route, and the other route would be going the 1115 demonstration waiver route, in which case you can kind of negotiate with the federal government on cost sharing on errors in eligibility. But in order for this to happen, we have to get approval from CMS on that amendment to the 1915C waiver or the 1115 waiver. So this can't happen without that agreement from the feds, if that answers your question.
Madam Chairman, if I may follow up then. So Delegate Sickles, I guess my concern, why wouldn't we make this rather a Section 1 bill that the department would have to seek whatever federal approvals before anything went into effect?
I'm not sure I have a good answer for that. I don't know if it looks like DMAS has left the building. If there's anybody here.
Timing is everything.
There they are.
Okay.
I see Will. I see Collings.
I guess one of the reasons you wouldn't want to do that is just the timing and the money that we could save immediately if we adopted this policy. And the Virginians we could serve more rapidly if we adopted this policy. I don't think there's that much risk in us
starting to pay for home and community-based service, and all of a sudden said, this person is not eligible anymore. Because these people are pretty, what's a good word? I don't want to use, they're people with they're older people with obvious problems.
It's a vulnerable population.
And it's vulnerable, yeah. So a vulnerable population, which is observable. How about that?
Can I note a couple things? Madam Chair, Delegate Orrick, just to note a couple things. So 9 other states have done this. So the federal government has dealt with these amendments to these waivers before and is in fact encouraging this because it saves money at both the state and federal level by directing people into the much less expensive home and community-based care as opposed to institutional care. So I don't view that as being a major hurdle to getting this done.
It's good to bring a bill that's going to save us money, Delegate Orrick.
It is good. All right, are there any other questions from our committee? Demas, would you like to speak about this? Here he comes.
How about Sarah? Yeah.
Madam Chair, Will Frank with DMAS. I don't know if this is helpful, but
don't say anything.
Right, we have no position on this bill.
Mr. Frank, it was so good to see you this evening.
Yes, we have no position on this bill.
Great.
However they want to write it is how they want to write it.
All right, cool. All right, this bill is back before our committee. I'm sorry, are there any? I can't remember if I asked about opposition, but all right. Are there any? This bill is back in front of our committee. We operate by motion. It would have to be reported and referred to appropriations.
Move to report to appropriations.
Second.
Okay, the motion is to report and refer HB 2394 to appropriations. It's been properly seconded. Please open the roll, Madam Clerk, and vote. All right, this bill will move forward on a vote of 4-2. Thank you, Mr. Uber, Chairman. And last but never least, Delegate Candy Munden King with House Bill 2539.
Thank you so much, Madam Chair, and thank you for your patience as I navigate another committee. House Bill 2539 is one of the bills that is in our very exciting Momnibus package, which is 17 bills designed to address maternal mortality. And so what House Bill 2539 does is expands access to dental support for pregnant women. Virginia has what we think is a really good dental programs, but there are some ways to make it better and more comprehensive and to meet the needs of pregnant women. And one of those is the necessity for deep cleaning during pregnancy and more access to care during pregnancy, because there's been extensive studies about how dental care is related to preterm birth and other health challenges for mom and baby. I have been working with some folks, including the folks at DMAS, and having conversations about what is currently available and how we can expand that. But what is currently included in the legislation is to expand access to deep cleanings, to different types of preventative cleaning, to ensure that it is expressly written what women are entitled to. And then another portion of this that I think is really important is some reporting on how effective some of these expansions are. And so happy to talk through and answer any questions from the committee.
Great, thank you so much. Any questions from our committee members? Nope. Delegate Henson.
Not a question, just a statement.
Yes, sir.
I just want to thank the patron for bringing this bill forward. I know when I worked in different agencies from healthcare.gov and Medicare and even in other things, it seems as though dental is always forgotten. So to see this bill come forward, it does something to my heart. So thank you, Delegate Munden King.
Thank you.
Great, thank you so much. Delegate, okay. Are there any folks in the room who want to speak in support of the bill? Oh, here we go. Yay. Good night. Good evening. Yeah.
My dear, we have more in common than you know. I am delighted to be able to support Delegate Monday King's effort because, like yourself, Delegate Henson, Madam Chair, one of the things that deeply troubles our organization is that we don't move quickly enough to provide enough kinds of support systems and services to pregnant women for themselves, for their babies, for the entire family experience that they have. And it is absolutely a well-known fact that pregnant women do not necessarily understand the threat of tooth decay and other issues that arise from a change in the acidity in their biological system, their mouth, et cetera. There are lots of things that happen. So the idea is completely forgotten most of the time. So the delegate is correct, and Delegate Henson, your comments are also correct, that it's low on the totem pole of concerns. Anything that the Commonwealth can do to advance the stability and safety and security of moms, pregnant moms, moms before, during, and after pregnancy, we 100% support. You're very welcome.
Great. Thank you so much for staying through the evening.
You're welcome.
Are there any folks who wish to speak in opposition to this bill? All right, it is before us. If it moves forward, it does need to be referred to appropriations.
Move to report and refer to appropriations.
Okay, the motion to move to report and refer to appropriations has been properly seconded. Madam Clerk, if you can open the roll. Delegate Munden King, as a daughter of a retired dentist, your bill moves forward on a vote of 6-0. Thank you so much for bringing this issue forward.
Thank you so much, Madam Chair and members of the committee.
All right, and so our marathon subcommittee meeting is now at its conclusion. Thank you, everyone, for staying with us through the night. Thank you, committee members. Bam.